Advisory Council. This is our first meeting being held as an open meeting. Kinks with regard to how to do that, so I appreciate. As I mentioned, both at the Joint Advisory Council, which is a joint DOH last week, we did receive an opinion from the Committee on Open Government in December that instructed that any of our statutory advisory bodies ought to be conducted in accordance with the Open Meetings Law. That is what we are doing. So this meeting is taking place in Empire State Plaza, which is accessible to the public. What we have is a webcast for those who are have a public comment period at the end of this back of the room. And that is simply so we know who goes first, who goes second, and so on. If we do end up having folks public commenting and here for that purpose, I would just appreciate that you keep your remarks to deference to others who may also want to share their. That being said, I should have first introduced myself, Roger Bearden. I'm the Acting Executive Deputy Commissioner, and to my left.
Not sure how to work this.
I think you just talk. I think they're all on.
Oh, okay. My name is Shmika Andrews. I am a member of the council, and I am the outreach coordinator for the Self-Advocacy
Chester County, Hudson Valley, DDAC.
I'm Vicki Haifa, representing Sheila Carey from the Developmental Disabilities Planning Council.
Michelle Judah, I'm a parent and the Executive Director of Parent to Parent of New York State.
Hi, Dolores McFadden. I'm the Director of Developmental Disability Services for the Orange County Department of Mental Health and Chair of the Systems Committee. Michelle's my co-chair.
Thank you. So we were going to begin today with a presentation and feedback from the Commissioner. So with that, I will ask.
Thank you. So it's a pleasure to see you again. I have met many of you, not all, and I knew you were not Sheila Carey, so.
I know.
It was a trick question for me, so. But it's a pleasure to be here again 3 months later and have my feet more or less under me at this point. So I wanted to kind of share my perspective on my first 4 or so months and talk really in a thematic way about what we do and where we are going. I guess I have to offer a caveat that I am not setting policy. I'm actually trying to stimulate discussion. So the things that I'll talk about aren't necessarily for the purposes of saying this is what we're going to do, but actually ask all of you for your input as to, what we should do and how we should do that. So it's only the end of January. It seems like a long time ago to me, but I was still a practicing physician seeing people with developmental disabilities, providing primary care, mental health services, managing seizures. And then suddenly found myself here Our program, it's a fairly large part of state government, and I think of it really as a business or a corporation. You know, we have about an $8 billion budget. We have about 19, 20,000 employees, and we support 140,000 individuals. It would be a good idea. Thanks. Got ahead of myself while I was there. We have multiple roles, and I think that's what's here next. So we're obviously a policymaker as a part of the state government, but we are also a regulator and a payer and a large provider. So we have something in common with almost everybody. You know, we can identify with our providers because we are a large provider operating 1,000 group homes and supporting 7,000 people in residential services. And so our opinion about things may vary depending on kind of where we sit. Our mission, this is right off our website, to help people with developmental disabilities live richer lives, and our vision to help people experience health and growth and live in the home of their choice and to fully participate in their communities. These are things that I think are the foundation and the bedrock of OPWDD. But you also need to understand that they don't occur in a vacuum. That half of our funds are obviously from New York State, actually slightly less than half. The other half come from the federal government through Medicaid. And the interests of our individuals, families, self-advocates, providers, OPWDD, New York State are not necessarily all aligned, in particular when it comes to the relationship between ourselves and CMS, the other partner in the funding of OPWDD. So it's really important to understand where CMS is going so that you can understand what our partner is telling us, so that when we communicate with you, we all have an understanding of, you know, the why and how. So the triple aim is something that I'm not sure most of you are familiar with. When I was working with medical students, I would tell them this was the most important article that they should read. Up until, you know, from 1965 until 2010, the healthcare delivery system was built on the Great Society premise of Johnson and Medicaid and Medicare. And in 2010, that actually changed. In the Affordable Care Act and in CMS, for the first time, there was articulated a health policy goal related to cost containment. Okay, so the first goal was to improve the patient experience of care, and the second was to improve the health of a population. But the third explicit goal was to start to reduce costs. And that is a revolution. It happened in law, a law that nearly all of us, I imagine, would support, but it's part of that equation. And it informs much of what CMS does through policy and through funding initiatives. So, for example, you're familiar probably with the DSRIP program and the Balancing Incentives program. Those came out of the Affordable Care Act. They were designed to stimulate innovation in states with the specific goal of meeting the three aims in the triple aim, including cost containment. So implied in that is the fact that the way you pay providers, healthcare providers, long-term care providers, changes their behavior. So there are a whole bunch of initiatives around alternative payment models, things that are associated with this idea of value-based payments, bundled payments where you take a bunch of services, you throw them together and you pay one fee for that. You know, for example, like a hip replacement, you don't get an itemized list, you get one bill for hip replacement, which includes the pre-op, the operation itself, the post-op care, the hospital, the rehab, everything. Shared savings, which some of you may be familiar with in terms of accountable care organizations. There is an accountable care organization specifically for people with developmental disabilities in New York State. That's a shared savings arrangement with a Medicare program. So when you change the way you pay providers, it changes their behavior, and that may have both positive and negative consequences. So as we look at the way providers are paid, we need to be attendant to the fact that not all changes in provider behavior might be positive. So that's where the regulator steps in. If you give someone a capitation payment and they cut back on services that are necessary because they've been paid prospectively, the regulator needs to be able to look at that and say, oh, no, that was really an important service. You were paid, but you need to continue to provide that service. So these are the things that are different about our system since 2010. And you can see the triple aim is in actually Obamacare. It's in the HITECH Act, which was the law that funded the development and implementation of medical records. And it's in other laws that you don't even know about. It's like something called MACRA, which was the Medicare and Access and Child Health Insurance Program Reauthorization Act, which included initiatives around merit incentive payment systems, or MIPS, big deal for hospitals. We don't think about it. But alternative payment models. Right now, I think the Department of Health is working with a large health system in New York to explore alternative payment models for children. And those are the beginnings of really profound changes in the way that the health care delivery system, including what we do, functions in the future. The triple aim didn't get incorporated into everything, and most noteworthy to me was the Class Act, which was a part of Obamacare, which was the long-term care benefit insurance program that advocates fought so hard to put into Obamacare. It wasn't funded. Nobody, Democrats and Republicans, could agree what to do about long-term care insurance, and it was pulled out of the act in 2013. So it tells you a little bit about something. Healthcare is easier than long-term care. Healthcare, people understand, I'm talking things like the Medicaid state plan program. It's easier to understand that the providers, the payers, the way the providers behave. It's much harder to deal with long-term care. It scares people, and it scares me. We've seen some kind of innovations that kind of at the margins, looking at reforms to the way long-term care services are provided. Things, as I've talked about, money follows the person, balancing incentive programs, DSRIP, health homes. But those don't fundamentally change long-term care. They kind of try to find ways to nudge it a little bit. The real challenge is, how do you provide long-term care that is responsive to people's needs and accommodates the fact that folks are getting older and need more and more assistance, and weighing that against kind of the values that I outlined at the very beginning, which is to help people live better lives in their own communities. That's a really tough balancing act. And for as long as you'll be working with me, that's going to be at the top of my list, is how do we balance resources that we have and the goals, the vision, the mission that we have articulated. That is a conflict. That's going to be difficult. There will not always be agreement. So, coming into my new role, the first question for me that's always been the biggest one in looking at organizations is, what is the organization? How does it work? And collectively, kind of rolled up in that concept of culture. What's the culture of OPWDD? And I kind of define that as the collective effort of our entire workforce. And in the case of OPWDD, it's not simply state employees, it's everybody. It's all of you, it's all of our providers, it's our self-advocates, our individuals and families. That entire group of people create a certain culture. And what I think we are going to have to do is go back to, again, to that premise of the federal government, which is the majority investor in our system, would like us to change, and we need to be talking about how that change can occur and whether that affects our mission and our vision. And that breaks down at a lower level into strategies around service delivery, the budget, how our systems operate or don't operate effectively, the quality of the human resources, and by that I mean things like DSPs, direct support professionals. Do we have a sufficient workforce of qualified individuals to meet the needs of our system? Services, what are the kinds of options we can offer to people? And again, who are our stakeholders? And stakeholders is a really important issue. So cultural change, again, from a very high level where I'm coming in and sitting, is to look at how we do things, how we can change to do some of those things more effectively. I'm asking a lot of questions inside OPWDD, which is helping me orient. I'll probably ask questions here. I'm like half Russian and half Irish, so I have like this kind of crazy optimism and then this kind of deep despair of darkness. So depending on the day that you get me, I might be saying we're going to go forward and go forward, but what happens if it doesn't work? So with managed care in particular, that's the kind of agenda item that was placed before me as I walked in the door. We're looking at how do we implement managed care? What can we accomplish with managed care? How is that going to be an innovation that we can use to benefit all of us? And at the same time, what if it fails? What if it fails at point A, at point B, at point C? What are the consequences of that? How does that affect people who are in managed care? How does it affect our providers, all the stakeholders that we mentioned? So simultaneously, we're planning for success and we are planning for failure. The stakeholders I mentioned, we have many stakeholders. They are not all aligned. Individuals and their families are our primary stakeholders. We are part of the executive branch, which means that we don't appropriate funds, we administer funds. So we don't make money. Folks think, well, you're OPWDD, you can get more money in your budget. And no, I can't get more money in my budget. I have to advocate the same way that all of you do. And I have some constraints as to my ability to advocate because I am an employee in the executive branch and my boss actually tells me what the budget will be. The legislative branch does the appropriations, you all know that. You're very effective advocates. But we also have state employees and unions who are stakeholders in what we do. I can't deny that. There are 19,000 employees that are part of OPWDD supporting, as I said earlier, 1,000 group homes and 7,000 people in certified residential opportunities. We have a very large delivery system with partners in the nonprofit and for-profit world. So this isn't a cohesive group. This is not a group of people who are all aligned, all saying the same thing. They're actually, in many respects, competing with each other. So if you go back to the budget and we have a fixed amount of money, we may have a group of individuals advocating for increases to salaries for DSPs. We may have a group of individuals advocating for increases to nonprofit budgets because of cost of living needs. And we may have individuals and families who are advocating for more services because they either don't receive any and would like to receive services. They've qualified for the first time, or the services that they receive may not be sufficient, things may have changed, and they would like more. So we have the challenge of balancing the sometimes competing interests of our stakeholders. All very important to us, not necessarily aligned or in agreement, and that represents a challenge for us, and it means that to some respects, we all compromise. Now, part of the process are related to our advocacy and advisory committees. I was shocked at how many advisory committees we have, and there are some that are required by statute, this one included, and there are others that are not required by statute that provide us specific advice on more narrowly defined content areas. In general, we're going to be looking at advisory committees and trying to make sure that the constituents in our advisory committees represent the people that we serve today and the people that we need to be serving in the future. I'll be honest, I think generally there's an underrepresentation of specific ethnic groups, of specific types of individuals with different disabilities, self-advocates, geographic representation. So we're going to be looking at all of those, and we can use the tools related to committees like bylaws and nominations and terms to shape advisory committees to align with, again, our current individuals and the people we serve and what we anticipate would be our future. One of the things I've thought a lot about with OPWDD is, what we have $8 billion, and what do we do with it, and why? What is our business model? I guess you're kind of getting to realize I have a degree in management, so I'm actually a pediatrician, but spent a lot of time in the management world doing lots of consulting around the country. And there are some ways in which OPWDD is all of these different kinds of investors, if you will. So on some level, we support programs that we hope are self-sustaining and may actually provide us with a return on investment. So if we conceptualize a program that has a diversionary effect, for example, like crisis response services or intensive behavioral services, we hope that by making that service available, we can help people be healthy and therefore stay out of the emergency room and out of the hospital. That's a kind of for-profit business model. You can calculate the return on investment. You put $1 in here, and you should expect at least $1 back in terms of the output. But a lot of our work, and by far the majority of it, is related to supporting nonprofit endeavors. And for that group, the challenge is a little bit different. How do we sustain the nonprofit partners that we have with the limited funds that we receive? The nonprofits all come to us and say, things are difficult. And I agree. And I put on my service provider hat and I say, I have exactly the same problems you do. My budget goes up, depending upon the state budget, 2%. If I get a 50% match from Medicaid, I can get it up to 4%. But in this year alone, our CCO business has grown by 5%. We've added 5,000 newly eligible individuals. We have the same inflationary pressures around staff and employees, a couple 3% salary plus fringe. And we have folks who are currently in service who need more assistance. So it's easy for me to come back and say, I've got 8 or 10% increased cost per year, and I've got a budget that's not capped, but is generally going to run about 4%. And I'm 4% behind all the time. I'm 4% behind today. Budget started April 1st. We're 4% behind. So I have the same kinds of pressures that all the providers have, except I'm a really big provider. So my pressures, to me, they look pretty daunting. So we actually also support innovation. Is that kind of a philanthropic model? Is that what a foundation does, where they give money and say, go out and do something really interesting? We don't support as much innovation as we would like. We're going to be talking with providers and individuals and families and other stakeholders about what kind of innovation we can develop that goes back to the premise of the triple aim of keeping people healthy, improving the experience of an individual's care, but also looking at costs. So the first item, the diversionary programs that can give us a return on that investment, are things that we're going to tie to innovation. And then, finally, we are here to do good. At the end of the day, the most important thing is, did we accomplish something valuable and important and good with the $8 billion that we spent in the last year? So you can see sometimes, depending on who we're talking with and what we're talking about, we might flip from one kind of business model to another. I mentioned some of this, and I'm going to skip it because I don't want to take too much time. So I think one of the reasons I was asked to take this role was, was because I have worn many different hats, but one of those hats is related to managed care. I did a lot of writing and publishing and teaching about managed care. I've run practices in 3 states. I've been paid basically along every kind of model that you can use, whether it's contracts or fee-for-service or capitation or shared savings or risk contracting, and I understand how those can be used to support and change provider behavior. I've been on the board of 2 managed care organizations, one which was a provider-led plan, which went out of business because it was a defensive effort. It was created to protect University Hospital and the University of Medicine and Dentistry in New Jersey. They never bought into the concept of trying to keep people healthy so that they could stay out of the ER, stay out of the hospital, and then the plan could operate. Instead, their goal was to support the status quo, to support the hospital, keep it full, and you can imagine they didn't succeed. They had a partner named Centene, and when the plan was unable to operate, Centene bought out the remaining shares and converted it to a for-profit, and I transitioned onto that board. So Centene has a combination of state and national boards, so I was on the state board. And that was a very interesting experience because a completely different business model for a managed care organization. Very skilled, very deep knowledge set, relied a lot on data, but very different. So from the perspective of New York, having had experience with both the success and failure of a provider-led managed care approach, it helps to inform my perspective on what we are proposing to do here, which I'll talk about in a bit. So I think about why the whole thing about managed care, because it wasn't my idea. I kind of came in the middle of the conversation. I think there are 2 separate problems. And they're not these problems right now. The first problem, I think, is really access. And I tie the access issue to the state plan services because it kind of fits my theory. I haven't heard a lot of people say that they are thrilled with their access to healthcare services. You know, doctors, hospitals, pharmaceuticals, rehab services, dentistry, mental health. And that's not something that OPWDD really addresses. That's something that is in the scope of the Department of Health around the Medicaid state plan, and the Department of Health relies on mainstream Medicaid managed care programs to address the issue of access and quality for state plan services. And I think that's one kind of core issue. The second issue is, I think, around equity or fairness. And that, I think, is something that really sits with us because we're talking primarily about long-term care services. You know, the question is, you know, who gets this or not? Who gets how much of this or how little? And you just look at all the service modalities that we provide, whether it's self-direction or family care or certified residential opportunities, the question of, you know, how much we offer, who gets it, and why. These questions of equity, that to me is really something that we own. So managed care can help us in those 2 regards. One, which is, I think, improving access to Medicaid state plan services, and the second is helping us with this challenge of equity and how we allocate the resources that we have. I'm saying managed care can help us. It doesn't mean that we are sure that it will. We have this third concept, which is probably related to the third part of the triple aim, which is what is euphemistically called value. What most people mean by that is savings. But for us, the question of, you know, how to create value, how to create savings, and what to do with those savings is really unresolved in some respects, because I don't even at this moment know who all of our shareholders are around the proposition of managed long-term care and how value gets created and where that value is allocated. And I'll talk about that in a minute. That may have been a little too abstract, but it'll get there. So we talked a little bit about our costs going up. I don't need to reiterate that. I can tell you, so going back to this issue of the value proposition in managed care, particularly long-term managed care. So I talked about the stakeholders. I think the discussion around value and savings is very different when there are for-profit entities as part of the discussion. So if we were to save $1 and the stakeholders at the table were individuals, families, our provider agencies, self-advocates, and the managed care plans that we support, we can have a discussion because we all have the same values and the same basic goals about what to do with any savings. If you take a for-profit shareholder who has a different constituent and a constituency that wants a return on their investment, they bought stock, they want to see the stock price go up, they want to see a dividend. You put them at the table, and you have to have a discussion about how you allocate value or savings. I think it's a very different discussion, and it makes me uncomfortable. So in my discussions with, I think, everybody, and particularly the Department of Health, I'm really committed to the concept of provider-led and, in particular, nonprofit. And I want as much control of that discussion as possible by nonprofits and our providers, and hopefully that affords everyone else a voice in that discussion. Really uncomfortable with for-profits coming to the table, for-profits putting up all the capital, and then coming back and saying, we put the capital in, we take the savings out. I no longer understand what the value proposition is. And then I have fundamental questions about, can managed care address the equity problem, which was the whole point in the beginning. So that's more concrete. I also have to say, again, because of that kind of pessimism that I often have, that if whatever we do were to fail, we're not going to get a do-over. So let's say we had created a managed care system that was designed to deliver state plan services, acute healthcare services, and that failed. I don't think they're going to, the higher-ups will come back and say, okay, fine, we'll dissolve all that, you take all those funds back, and you can start over. There are consequences. So if our state plan dollars are in provider-led plans and it fails, it probably goes over to mainstream plans because they're actually sitting there and they're delivering that service right now. And about 25,000 people, individuals who we serve at OPWDD, have already joined a mainstream plan because the mainstream plan provides better access to healthcare services than the fee-for-service Medicaid program. And those 25,000 people are an important stakeholder and constituency in our discussions about Medicaid managed care. So while some folks don't want it, 25,000 people chose it because they feel it was better than the fee-for-service Medicaid alternative. Those guys aren't coming out of fee-for-service, out of managed care back into fee-for-service. There's no do-over for them. They're going to continue to be in mainstream managed care, and it's going to complicate our discussions. So this evolves every day, and last night I couldn't sleep because one of the items just jumps up at a higher level. And I think what's happening to me over the last 4 months is, there's a problem and we peel it back a little bit and it's actually a bigger problem. You peel it back and then it's kind of a structural problem. And I think we've got some structural problems that we need to address to be prepared for managed care. And I'll be honest about our deficiencies. At the same time, I think as we've talked about managed care and the partnerships that we're trying to create with provider-led organizations, those provider-led organizations have a lot of work to do also. So just within OPWDD, we have to improve our capacity around planning. You all know Kate Marley, and that's a good thing and a bad thing. She's great at planning. She writes all the waivers. But, you know her because she's like the only person there. That's not completely accurate, but it's a really, really small planning shop in an $8 billion organization. we really don't have a strong project management function. So the folks who launched CCOs were pulled from the Division of Quality Improvement, and they launched CCOs, and then they're being refocused on SIP-PLs, the provider-led managed care organizations, and they'll probably be repurposed after that to do something else. So what happens is you launch a program, and then there's not a lot of follow-through because you don't have project management, project evaluation, and the trailing edge kind of is falling apart as you're going forward, which I can explain in more detail in a second. We have to move from quality assurance, like the regulator saying, here's what the regs say, to support quality improvement, giving providers some flexibility to improve the quality of care in ways that they know best. So we have to look at whether regs are constraining behavior, payment models are constraining behavior, what are the constraints, what can we do to create win-wins with providers. Information technology is a big problem, and a good example, this is what kept me up last night, is the fact that we don't have a lot of data. I'm quite surprised at the lack of data that we have. In many respects, we operate in the blind. So for example, self-directed services is a really important program. It's an alternative to out-of-home placement. We want to support it, but it's not part of an integrated IT system. So authorizations happen over here, and the authorization process may vary from region to region, highlighting the fact that we don't have centralized policies and procedures, which we need to get to. But it happens at a regional level in a separate process. And then services are delivered and claims for those services are submitted, and they go somewhere outside of OPWDD. And then the claims data trickles over through the department budget into our budget office. And 3, 6, 12 months after the authorization, budget comes back and says, hey, what you did 3, 6, 12 months ago created this outcome from a budget perspective. And that kind of reactive system isn't effective when you're talking about managing a large organization. So we have a big IT lift around creating an integrated technology platform that incorporates the basic functions of what we do, which is to authorize, to pay, and to plan. Because right now, because we can't do that, we are behind. And we can only find out that we're behind months and months after the fact. So we have to now be reactive around our current budget. And that has consequences that may not be pleasant. So, whoops, where did I go? I think this whole thing was moving around while I was here. So, for example, the CCO launch. Now I have to say, I was running an MSc program. I had written and obtained funding for the Health Home Serving Children program. I applied to become a CCO. This was all while I was at Montefiore Medical Center. So I was on the outside. I was running MSc, familiar with health homes, and applying to become another health home. So it looked like a really massive project to me to consolidate care management for 100,000 people on a single day with a total cost of about $500 million. It was a really big lift. And I was surprised it got off the ground, which is really a big accomplishment. I'm not saying that everything looked great from the outside, but just getting that thing off the ground was really an accomplishment. And I thought OPWDD deserved some credit. So I'll take the credit now. But there were things that OPWDD didn't anticipate and that we now have to live with as a consequence. So for example, all of the CCOs actually chose the same electronic health record vendor. They all provide a single service, more or less. They develop life plans. They're paid using a really simple model called capitation. You tell us the number of people, we multiply that by an amount, and you get that check on the first of the month. There are really simple metrics that you can use to evaluate performance. For example, what percent of individuals have life plans? What percent of individuals have had the IAM or the CAS or the DDP2? But we never built the connection between OPWDD and the CCOs. There's no electronic upload of data. There's a sideways upload into Metasched. Well, we don't have a relationship with Metasched. They're not one of our vendors. So we don't see the care plans. We don't have any input into what care plans suggest might be appropriate levels of service or not. There's no utilization management function applied to those care plans by the CCOs or by us. So they have the potential to drive a lot of costs because they are responsive to people's needs and incorporate service recommendations based on what families want. So we can't upload the data. So when we ask the CCOs how they're doing, we don't know. We have to ask them actually to send us data on paper in Excel. And we're doing that. And then we're meeting with them every month, and every quarter we're setting benchmarks. But that is a really primitive way to run a $500 million service line. So we are trying to address that on the fly. It should have been done before the launch, but it has to be done eventually. Now, I can tell you, as we think about SIP-PLs and managed care, we're not going to repeat that mistake. I mean, that's crazy. We made that mistake once. We're not going to make that again. We're working with the CCOs to achieve 100% compliance on those relevant benchmarks that I mentioned earlier. Everyone should have a care plan. Everyone should have an assessment that informs the care plan. They're woefully behind. We've had lots of internal discussions with them. There will be public discussions in October when we have told them we will put their performance online relative to those metrics so that everybody can see what they're doing, much in the line of what CMS does with nursing homes and the 5-star program. But we think disclosing that kind of data is really helpful. Okay, so I talked a little bit around managed care. I've talked about, maybe the value proposition for state plan services is different than long-term care services. In state plan services, maybe it's an access issue, whereas in long-term care, we might be talking more about equity. My experience with managed care is that there are some things that are easy and some things that are hard. I talked to you about the fact that I think the value proposition for state plan services is easier. If you keep people out of the hospital and the ER, you save money, and you can reinvest that money in other services. I don't know what the value proposition is in long-term care necessarily. The most expensive part of the long-term care system is the residential component. So if the value proposition is we keep people out of residential services, that's, again, if we all agreed to that, so don't get ahead of yourselves. But if we did agree that that was the value proposition and we actually accomplished it and reduced the number of residential opportunities to create savings, the question is, where do those savings go? Do they go to individuals and families? Do they go providers? Do they go to the SIP-PLs that created the value? If we have for-profit partners, does that value go out to the for-profits? And then there's the kind of unspoken constituents, stakeholders, the individuals who don't receive any services at all, So it gets to be really complicated. This issue of the value proposition of long-term care is not simple. So I'm a fairly concrete person. I think things are better addressed in a stepwise fashion. I've talked to you about what we're trying to do with CCOs. If people don't have care plans, I don't know how we can go to managed care. So we are telling our CCOs that they need to be working very quickly and efficiently and effectively to ensure that the CCO functions the way it's supposed to. Everybody has a care plan. It's a high-quality care plan, and begin thinking about how care planning affects service volume and the demand for services. Because if you're a managed care organization, you have to be able to connect to the CCO, not just developing care plans and generating volume, but managing that need or that request for services. And to be honest, I'm not sure the CPLs recognize that that is something that they have to master. Because if they don't, and they are at full risk, the CCO partner in a CPL could easily push the CPL over the top. So as we look at things stepwise, it's much easier to do state plan. There are hundreds of HMOs around the country. They all manage Medicaid state plan services. It's not that complicated. So we're talking with folks about demonstrating competence as a CCO in life care, life planning, developing competence around management of state plan services, where there are opportunities to create value. That's why managed care exists. These companies can make money. They can create savings. Show us how to do that. That's not as hard as managing long-term care. And once you've managed that, we'll talk about managed long-term care. But I'm not discussing the criteria, the timing, the scope. All I'm telling folks is that when we're ready to talk about managed long-term care, we'll have that discussion. But we're not even ready to have the discussion about managed state plan services because we're still trying to deal with very basic issues around CCOs. Some of them issues owned by the CCOs. Some of those are issues that are owned by OPWDD. But we are not ready as a system to move into managed care because we don't have a basic care planning function right now. We're pushing. We're going to try to get to that by January. So it's not like this is a permanent impediment, but it's something that has to be overcome immediately. Oh, so that was it. I hope that doesn't feel like anticlimactic, but that's kind of, I think, where I am in my thinking. I think I don't know the seasons of OPWDD or state government, but we are about to end one season and enter another. This week, I assume the legislature will end its session, and that begins the informal start of budget season. So we will be preparing a list of topics to discuss with my boss in the chamber and with the Department of Budget, and it'll be high level, and it'll include things like, our IT infrastructure, overall investments in residential services and other programs. Things that, again, with an $8 billion budget, things that are like $5, $10, $20 million, they're not the big priorities. Those are things we're going to try to look at over the course of a year, those smaller initiatives. But we've got some real questions about, what does the budget look like given those inflationary pressures, given the increases in demand, the fact that our CCO volume's gone up by 5%, those kinds of basic, really fundamental issues that were things we'll be talking about in the next month or two.
Before we go to Q&A, there's a request from WebEx land that people lean into their mics like I'm doing to facilitate people hearing. People could hear you, Commissioner, but some of the prior comments were not.
Well, they probably couldn't hear me. I have a voice that doesn't carry, and, I just have to learn how to be more attentive to that. So I apologize.
No, people could hear you. It was
hear.
in the prior comments that some folks had some challenges according to that.
Okay, so I don't want you to think I just set policy. I think I've done this presentation 5, 6, 7 times. People have run out of the room with their hair on fire. That's not the goal. It's really to create an environment where we can have a constructive dialogue about the complexity of our system, where it is and where we want it to go. Recognize that there are competing interests even in family here, and we're not all going to be happy, but to at least put everything on the table and have that kind of a discussion. I think people aren't necessarily familiar or experienced with that kind of interaction with a commissioner. That's just the way I'm built, and I can't change it. So I would much rather kind of tell folks things and ask for your feedback and have difficult discussions rather than none at all. So, with that.
You want to come back around to the front so you can reclaim your nameplate, and then maybe in deference to the chair, to Nick, maybe if you want to as feedback on the commissioner's presentation and thoughts, if there are some.
It's usually not a shy group. Mary?
First of all, I'd like to thank the Commissioner for the first time that we have some really true, transparent answers to questions that we down in the trenches, parents and families, have been saying for a long, long time. And to hear it from the top, and with, I greatly appreciate that you recognize the problems with CCOs, with the delivery of service, with the lack of training, with some important issues that some of our parents have been discussing, and that I see every day on my listserv what families are going through on the ground. And to hear it from the top is
Sorry,
just
Mary, I don't mean to interrupt, Mary, but you're coming in and out from the mic.
sorry.
That's kind of...
And I would just like to say I really appreciate, I was quite astonished at some of the comments, and I'd just like to state for the record, I am 100% Irish born, US citizen, not deportable, I hope.
No, well, thanks for your comment.
I want to come at it from a parent perspective, but I'm also an FSS provider where I deal directly with 125 families. So I'm thinking also from the feedback that they give me all the time. I too appreciated all that because while we have received information here, we have received it in the broad-based format. We have not received information in a discussion format, in a informative format. We've gotten information the same time everybody else has, and that's been a problem for us because we're then asked questions that we can't even help them to begin to be able to form their own questions. But one comment I'd like to make is this is a human service delivery system, and we want to maintain that. First and foremost, we really want to talk about the needs of the individuals, the needs of the families. I understand there are various stakeholders, but if we did not have the individuals, we would not have a system. And so I just want to emphasize that because, Commissioner, I didn't get that feel in your presentation. I certainly appreciated what you gave us, but I think there is that huge aspect we don't want to lose.
Thank you.
Follow up on that. One of our members, Betty Piper, who has been a member of this advisory council for many, many years, longer than me, is facing extraordinary challenges today. And she is extraordinary challenges. And I think you're all aware because I think she made it known to the council.
Mary, I just want to pause. Just remember, this is being webcast around the state, so
Yes.
I would
Yes.
very much want to respect
I have
Betty's.
Betty's
Okay.
permission to bring it up at
As
the
long as
council.
as long as I just want to respect her privacy, and because
Yes.
it's not just this group.
No. I think many of the council members know that I have her permission to speak about it on the agenda. She is facing extraordinary challenges with her son, and she and her husband are today in their 80s, still caretaking and still running around and facing their son being placed several counties away in a health home because of tube feeding issues. My daughter has a feeding tube. I train all my aides. I can do tube feeding in my sleep. It is not a service that's necessary to transport a person several counties away to receive services. It can be easily delivered at low cost. And I have fought this battle many years ago with CDPAP services, which our aides can provide. Now, OPWDD, ComHab, they are supposed to be able to provide tube feeding services. trained by a nurse, but they can provide them. And I haven't seen any movement on that, so I don't know where it actually stands at the moment. But this is just exactly what Mary Ellen said. These are human issues that if our families on the council are going through these issues right now, this is what you as commissioner have to keep in mind going forward. As many of our commissioners in the past always knew that it's the families, and you have to listen to the families. I don't care what CMS says. We go to CMS meetings. They do not live in our homes. They do not have to stand in front of 2 quadriplegic daughters when the aides don't show up because they're getting low pay and they've decided to take another job. How do I get my daughters out of bed? How do I tube feed my daughter who can't get out of bed? These are the human issues that face our families on the ground every day and have to be at the back of the minds of you and your staff when you're sitting at these meetings deciding what is going to happen to us going forward. You have to think of, and you have to listen to the families as opposed to other councillors where money, the big mighty dollar, is the deciding factor. And we families have worked with self-direction, with CDPAP, to bring costs down. And we provide the work. We provide training that otherwise would be paid for by staff. All of this so we could get quality of care for our family members. We've taken on that responsibility to save costs because we understand. We get better service for our adult children or younger children, and we have supervision of what's going on. We can vet the individuals that come into our home. We save a lot of money, and we are the best people to advise you on how to save costs. But it doesn't mean cutting costs to people who truly need long-term care, short-term care, and we keep our kids out of the hospital. Trust me, that's our primary goal. So I just would like to let that rule whatever we're discussing today and have it always in the back of your mind. That's the goal of OPWDD. And just what Mary Ellen,
Well, so I don't like to.
all of our parents have said for many years.
I don't like to talk about it because it's not mine to say, but I am a family member of a person who's eligible for state services in another state, and I was a DSP. So I share your perspectives. What I'm trying to do for this group and others is to kind of explain the complexity and engage people in understanding the multiple perspectives that are valid and have to be balanced in the context of setting policy and allocating resources. So I'm open to working with people who can operate at those multiple levels. I do understand that our system is designed to support individuals and their families, but I am particularly grateful for individuals and families who recognize that we don't have unlimited resources, and that because our resources are limited, that compromise is often necessary. So I hope in our future discussions that we can have that type of a balanced discussion, trying to weigh all of the complexities, because that will help me and allow me, I think, to be more transparent in working with everyone. We can talk about the competing interests and how those are resolved, because there are competing interests. I think I tried to make that clear. I think it's clear to me that at some times one interest is supported and the other isn't. So it's not as simple as it seemed to me before I got here. And hopefully I can help you all understand that, the complexity also.
I think this discussion was excellent. It's a perspective that we, I think, have never been offered before, and I think it's very helpful for us to have that. But on the other hand, when you start talking about looking at where the biggest expense pot is, and it's residential, and paring back on that, Right now, I can't tell you what is going on inside me. It raises the anxiety level tremendously. There are a lot of people, including my son, who cannot survive without 24/7 residential care.
So
And we don't want to wait until the parents die and then force them in at the very last minute. It's just inhumane. It's life transition, and you need to respect that. And it takes a while for people to grow into their new life situation. You can't expect that when people die, that the individual will be able to process all those traumas at the same time, the loss of the parents, the loss of the home, all that, and survive in a I can't think of the right word, humane way. So, certain people are always going to need 24/7 care, and that can't be touched, and there's no negotiation about that either. That's health and safety, and if OPW can't do that, then we're in big trouble, because that's really the bottom line of the mission.
Yeah. So I want to apologize if, again, going back to the first point I made about any misperception about this being policy. This wasn't an articulation of policy. There is no policy to reduce our support for residential services, and there's no policy to reduce our support for ComHab or for self-direction. That's absolutely clear. But the challenge is that those might be perceived as competing interests, and with a budget that is constrained and growing numbers of individuals seeking services, there will have to be compromises. So there isn't a policy decision about one or the other or the other. It often doesn't end up in policy. It ends up in the form of budget. It will always be a need for 24/7 support for some individuals. The challenge for all of us is, which individuals need 24/7 support versus which individuals would like 24/7 support versus which individuals don't need it and shouldn't get it at all.
And this can trigger a very useful conversation about expanding the types of residential models, because right now it's kind of all or very little, and there's not that middle ground that we're missing. In supported living, there's a max number of hours that you can have support. That was the way it has been, and that's something that needs to be looked at.
Well, one of the things that's easier to get an understanding of is ComHab, for example. So we pulled all the data on ComHab. Community Habilitation supports 28,000 people. Its total cost of $440 million, which sounds like a lot of money. It's really only about 5% of our budget, but it's an important program. When you look at how community HAB dollars are allocated, the average expenditure is about $15,000 a year, but 90% of the individuals receive, on average, $10,000, and the other 10% receive about $62,000, $63,000 a year. So there's clearly a question in my mind as to why, one group of individuals receives a lot of ComHab and almost everyone else receives much less. We, inside OPWD, have never really looked at that and asked why. And I think it's a reasonable question, and we will look at why, and we'll look at whether the benefit ComHab addresses what we've heard earlier, that it helps people stay out of more expensive settings. It helps people stay at home as opposed to moving into residential care. We need to explore all those premises and make a decision about whether, ComHab is a priority in terms of making more investments or not. The same with self-direction and family care and the other tools that we have to support people. And that's going to be a really difficult decision. So if you can afford to pay for some of all four, where do you put the next dollar? You split it into 4 quarters and each one gets 25 cents. I mean, it's one way, but I'd rather have a discussion that's based on data and experience with input from everyone as to where should we be making strategic investments, knowing that we can't afford to pay for everything. We want to support people in their homes. Out-of-home placements are the most expensive placements or options that we have. So, taking all that into account, what do we do next? Probably what's going to happen is the next dollar we get is going to go to pay for inflation, or to pay for expansion in the number of individuals that we serve. But those are things to talk about, and I'm really interested in your thoughts as to where we should be making investments and where we should be looking as we move forward into the future, because we are not going to have the types of resources that I think have existed in the past. We're not keeping up right now.
Mm-hmm. And before we leave, Margaret, just to your point, we have actually, residential subcommittee has actually spent quite a bit of time looking at those alternatives and some of the impediments to moving into different, because while we might have a huge gap between the 90% that received the 10,000 and the group that received the 60,000, there's also a very large gap between those who received the 60,000 and those that received certified. And how can we create a more continuum, if you will, of services? And that's something the residential subcommittee, and I know they're going to have some remarks later for today's group, but they can talk to that. So I just wanted to make sure that we acknowledge that. I know we've had a couple hands up. Donna?
Hi. Well, Ted, I thought that was a commissioner. Sorry.
Not yet. Maybe tomorrow. We don't know.
Yeah, acting committee until tomorrow.
Whatever.
And I thought it was a good presentation in terms of the layout of helpful as a structure to think about these things. It's a little overwhelming, to think about the kind of work that we have to do. But I just want to make a couple of points. One is that, for me, front and center, the value proposition, which I don't think we want to lose, is the quality of life. And we sometimes leave that out, because I've seen that in other systems where we're focused on things that we presume are related to quality of life, and certainly staying out of the ER in hospitals is one of them. But I think in our system, it's really been front and center, and I feel a need to say that only because I think it's really important for us to understand how do we really develop a system going forward that is able to speak to that in the true sense of the word. On maybe a more sort of practical level, there's a lot to unpack there. I'd love to have some real conversations about workforce challenges, because I think it's huge, and I'm not sure what the solution is. If I had one, believe me, I'd put it out there, but we can't ignore it, and I think we have to name some of the challenges that we have, not just in terms of, how do we deliver person-centered care and approaches, but that the workforce thing is just really affecting all of us, and maybe just spending some time dealing with some of the realities, because I think there's some real obstacles to what we're trying to achieve. That and there are some structural solutions to that, maybe, but I that's a key. The other piece I just want to talk a little bit about, there are some things that cost us money that don't add value in the system, and I'd love for us to really lay them out. And we did a little of that work, and Nick, I'm looking at you in the transformation panel.
Yeah, we did.
But if we can pull some of that stuff out, because we're still a long ways from sort of taking those the tasks out of the system that don't really add value to the individuals that we serve. And the other piece of that was the flexibility that we've said over and over again. Can we have a more flexible system? And we kind of still get stuck in the system. Some of the rubric is driven by CMS, some of it isn't. Sometimes we don't totally understand what is driven by CMS and what is driven by OPWDD. So I think that's kind of still out there in the ether. And so maybe there's some opportunity for shifting now, where we can redirect some of the resources toward higher value, if you will, for the individuals. One last thing, while I still have the mic, this whole issue of access to health care is a big concern to us. Certainly it's not integrated with long-term care in the way we would like, but there needs to be some significant payment reform on the healthcare side for us to attract primary care, specialty care, dental care, to serve people with intellectual and developmental disabilities. I have been involved in the district at pretty high levels in New York City, and never do we talk about people with intellectual and developmental disabilities. There are still some hospitals now who, I know they've contacted me in New York, where there are people who are sitting in hospitals with nowhere to go that happen to be people with intellectual and developmental disabilities. And so they're interested from a cost perspective, what are we going to, we have to find a place for these individuals. But we've been out of that discussion completely, and so we need to be in the discussion in the healthcare arena, but there needs to be payment reform on the healthcare side. And I realize this is OPWDD, but for us to be able to have greater access to healthcare. And I'm interested in knowing, and you might have the data, the 25,000 individuals that have opted in for health and managed care, what were the reasons? And I suspect, but this is completely speculative on my part, that some of it is because some of the family members happen to be in these plans, so that the individual wants to be in, like if you're in a Medicaid managed care plan, you want, of course, your son or daughter to be in that plan. There may be other reasons, and I think we have to learn from that, because I think we can't. We need help from the Department of Health as well, and I've said this publicly. We can't just develop a healthcare network that's going to be responsive to the needs of people with intellectual and developmental disabilities the way we don't have that access now, even with the Medicaid and the Medicare card. So how that is going to somewhat magically occur, I'm not sure. So I think we have to kind of think about what are the things that we're doing as a system, whether it's DOH with OPW, that is going to advance that, including and not limited to paying providers to and you know better than anyone in terms of, because you spent time as a physician serving people, and much appreciated, by the way. I know by my organization, because we work with you, but we don't have that. And Gary, I know you've done a tremendous amount of work, so we're not there yet, and that's a big problem for our folks. So I'm sorry, but I try to get everything in one.
Yeah, no, it's
in once.
You've stimulated a lot of discussion. Okay.
no, I've spent 35, 40 years in that space, so I totally understand it. Like those little factoids sometimes tell a good story. So New York State Medicaid fee-for-service pays 54% of what the Medicare fee schedule is. So when I came to New York in 2013 and tried to set up a practice and became a Medicaid provider and found out that I was paid 54% of what Medicare would pay, it was not a viable practice. Turns out New York's a really complicated state, and so there are the articled clinics, 16s, 28s, and 31s. We have 16 Article 16 clinics. They're not a substitute or an alternative to the low rates of reimbursement for fee-for-service Medicaid. I think the Department of Health's solution has been Medicaid managed care, and they've got 5 million people in Medicaid managed care, and they seem to be committed to moving forward in that direction. We have 140,000 individuals. That's less than 3% of the number of people served in Medicaid managed care. So, from the DOH perspective, they probably look at it and say, yeah, fine, 3% more, that's not a big deal. And that does address access issues to some extent. As the PI on two federal training grants. Here, the work that we did with the UCEDS, University Centers of Excellence in Developmental Disabilities. I was a member of the DD Planning Council. I understand the complexity. There's a lot there, maybe more I think than some of the providers see, but I don't know that the healthcare problem is something that we fundamentally own or can fundamentally change, and we do have to rely on DOH. So my point is to try to take apart this idea of managed care a little bit, that there are different problems, and managed care can solve them, but they're not necessarily all the same fix. So trying to deal with state plan Medicaid service access might be different than trying to improve how equitably we distribute resources on the long-term care side. That was kind of my point. I think on healthcare, we're just at the margins, dealing with smaller things rather than the big challenge, which is what health is doing. I don't know. That alone is complex enough. Long-term care is even more complicated than that. So,
Ruth?
Thank you. And Donna, that was like a load of things to think about. Thank you, though. But Commissioner, I want to thank you for presenting today, but also kind of giving us your roadmap of what's ahead and what the very real challenges are. And I want to also thank you for, sharing that information with us. And my hope is that you'll use us going forward. And I just want to say I don't envy your job, because there really is so much to consider and so many different moving parts. My comment or question really is, in your thinking and planning, do you have a sense of where state operations fit in terms of this transition into Medicaid or managed care? I'm familiar with OMH and OASIS, and we're really seeing things move along, but there's still a question as to where state-operated programs fit in the transition to managed care, and also going forward into a value-based payment structure. So just curious if that's on the list of things to get to, or?
Yeah, everything's on the list, and that's really kind of the challenge. I can tell you that state ops is not as simple as it might sound. The state ops incorporates two sets of services. One, I referenced the Article 16 clinics and other clinical services provided by state employees through OPWDD. The integration of that set of services into managed care will be a different integration if we stage it in, as I described, care management, state plan, and then long-term care. The 16s would have to be thought of and considered first, because they provide state plan services. It's even more complicated as you look at what will be happening in January, the movement of Community First Care Option, the CFCO, which incorporates community habilitation, is moving from our waiver into straight Medicaid plan, and that's going to affect about 4,000 people. So I'm saying there are some pretty much straight healthcare services that we have to figure out. There are waiver services that are moving from waiver to state plan that we need to figure out. And then there are the core waiver services that we fund at OPWDD, and I think they would probably be the latter part of the discussion. So the fact that state ops provides residential services to 7,000 people is going to have to be discussed, but I think that's at the latter stages of our thinking about managed care. It's not the first discussion I want to have. Sure. So it's not a dodge. It's just like, why take on something I don't really understand? And I certainly don't understand the value proposition. As you know, we haven't even finished and released the qualification document for the SIP-PLs, the provider-led plans that we want to support. Until we do that, it's kind of premature to talk about what the vision for managed long-term care looks like. As I said, are these entities 100% provider-controlled? Are they nonprofit? Really, to me, fundamental questions. We're still negotiating those issues with the Department of Health. So the long-term care side, there's a lot of questions and fewer answers. The first issue for state ops is going to be the state Medicaid plan services, including Article 16 and other clinical services that we provide directly. And I'm not sure how that's going to work either. But we'll get to that first.
Okay. Tammy.
Hi, Commissioner. I just wanted to first thank you for your comments and your presentation. It was enlightening. Thank you. The question I have is surrounding family support services, and I'm looking to see what your thoughts are on how family support services fits into our newer model upcoming. Also, in particular, there's a provider survey that's going out, and I was hoping you could tell us a little bit about that survey, and then perhaps give us some ideas on what the purpose of the survey is, what we're looking to gain from the questions on the survey.
So we met with the Family Support Council last week, and we talked a bit about family support services. Family support's a program that's 100% state funded. There's no match to it. So one of the things we did was walk through the budget and looked at what family support is providing. And in my mind, I'm very interested in areas that are duplicative. So for example, if we can take a family support program that's 100% state funded, and it looks an awful lot like something that we fund under the waiver, move those dollars to the waiver, double the capacity of those dollars and make them available to support more people. So intensive behavioral services, for example, spend about $4 million in family support, in the family support budget. It's unmatched. We have an intensive behavioral services program in the waiver. It's underfunded and therefore very poorly accessed. I've told them we will be looking for opportunities to maximize the value we can create with the dollar. So if they were here, I would tell them what I'm going to say now, which is I think we're going to be looking at whether we pull that out of that budget and move it over into the waiver so that we can double the capacity, go from $4 million to $8 million of intensive behavioral services, which we desperately need as a system. I can't comment on the survey, but I think Roger has more information than I do.
And we discussed it a little bit last week in the FSS committee as we were unpacking the global numbers that the commissioner was just speaking about. Because of the way the program is administered and designed, we don't have sufficient visibility into exactly what the money is being used for on the ground. So the survey is intended to answer that question. If we on a kind of aggregate level say that seems duplicative, that seems like an opportunity. The other movement obviously is a move to a broader case management system within the CCO program as compared to the MSC. There's care management within the FSS program. So once again, the survey is really just a data gathering, since similar to what the commissioner discussed in his presentation with respect to CCO data, we're not within OPWDD sufficiently aware of exactly how those dollars are being used, and so what the opportunities are. So it's a data gathering mission.
Questions? I know we're scheduling lunch for about 12:15. Michelle, we'll do another question and then take a break.
Yeah, I'm trying to think all my thoughts. Thank you very much, Commissioner, for your comments. I have to say that I applaud you talking very directly about the triple aim. We're certainly familiar with that at Parent to Parent. We get federal dollars. We're very familiar with the Affordable Care Act and know about that. And there's many times that I've been at meetings here or similar meetings where internally I've been saying, just say, yes, it is about cost. It is about, managing cost and making sure that we have a system that is sustainable, and that will be here, not just for our children, but for our grandchildren and generations beyond that. And we do have to look at those very, very real issues. One thing that I think is, I feel a little necessary to say, it repeats a little bit about what some of the other families here have said, is, in addition to the triple aim being part of the federal government's mandate, they're really doing a lot of talking recently about family engagement and making sure that families are at the heart of decision making at the systems level and being, involved in that. And you've referenced a few times how complicated, the systems are and how complicated they are even for the people who are in the business of writing the policies and the regulations and drafting the waiver agreements and negotiating with CMS. So you can only imagine how complicated it is for families to understand all of that. But I would also implore that there needs to be a continued effort. I mean, OPWDD was out ahead of all of this government push about family engagement. There needs to be a continued effort to include the families on the ground because it's tough getting into the weeds. I understand that. It's tough getting into the weeds of individual situations, but there's a lot of data to be gleaned there in terms of inefficiencies, ways that dollars aren't being spent effectively. It's really important to have that. I'd be really, two more comments. I'm very little concerned, I guess, to hear about the provider survey. Not that the provider survey is fine about family support services, but is there going to be a mirror effort to talk to families about what they see as is important in terms of the services that they're receiving, what they're not receiving? Families are the backbone of the system. We need them as the natural supports, particularly if we're trying to keep people in their communities and have them more successfully integrated in their communities. So I would want to make sure that families are part of that. And I guess the last thing that I'll leave, just having listened to all the conversation, is I'm very interested in knowing, this is a question to you, I guess, is to what is being done specifically to define value, and to come up with that. I agree. I was so happy to hear in your comments, that we don't just need care plans, but we need quality care plans. A lot of the metrics that I see regarding that doesn't really get to quality. It gets to how many are done and how many include this type of service and that type of thing. And I think that, that goes along with this value, and it goes along with, what are we looking for care plans to achieve? What are we looking for this process to achieve at the end? And I'm not really, who's part of those conversations? What's going into deciding how we determine quality and how we determine value?
Really good questions, and they're obviously not simple to answer. So I stressed at the beginning the importance of engagement and having constituents of representing the various stakeholders that we have at the table. I mean, there is a family support council, and families do have a voice in the deliberations. Obviously, you're here. We're trying to make sure that families and individuals are able to participate. As far as quality, there have been, I think, a lot of discussions about what quality is, whether it's the personal outcome measures that different entities use, more customized or tailored items, whether they're HEDIS or the CAP surveys that are done by managed care. I don't think that we have a clear consensus. The challenge is that quality really is in the eye of the beholder, and because people have different perspectives on what's important to them, there isn't going to be a unified single agreement about this is what quality is. So it tends to be conceptualized much more broadly and measured much more broadly. Sometimes it touches what's important to one person in terms of quality and not other things, whereas those items that weren't responsive to one person are exactly right for this other individual. So it's really difficult to conceptualize and then to measure quality and to use it as a tool in setting policy, because you end up with lots of different opinions. And value is kind of the same issue. As I said before, I think it's the concept of value in healthcare is easier to understand than the concept of value in long-term care. For me, value in healthcare can be a win-win. So if people are healthier, they're happier, and they don't consume expensive services. So if we can keep people healthier and happier and out of the ER and the hospital, I think that's a win-win. And you can tie dollars to that, and you can actually measure exactly how much savings or value is created. We don't own the healthcare system, so we're not going to capture value from that unless we have our own managed care plans. And so let's say we implement managed care and we create savings value. It's an open question about how that value is distributed among the shareholders, individuals, families, self-advocates, the providers that we rely on, the CPLs that help to create that. That's going to be a difficult decision. And that's why, going back to the first premise, I really don't want to have for-profit shareholders talking about the value that is created and how it's allocated. on long-term care, I don't have a really clear understanding of the value proposition, because if you apply the healthcare model, which is you target the most expensive part of the delivery system, the hospital, and everybody agrees you shouldn't have to go to the hospital if you don't need it, it doesn't necessarily follow that the logic would work on the long-term care side, where you target the most expensive service modality, in our case, you know, a community residence, and you reduce that. I mean, I don't know that the legislature would really understand that as value, when every year they're coming back and saying, here's an appropriation, create more capacity, because individuals are asking for it. So I think the value proposition of long-term care is more fraught and even more complicated if we have for-profit shareholders at the table having that discussion. So I just want to do the easy things first and get to the more complex things. And that's, you'll see that. That's kind of a pattern with me.
So I just wanted to, on macro vision of the commissioner to the micro, on the survey, we did make a commitment to the FSS committee last week that we would be working with them, getting that information. They are the statewide committee of a bunch of 13, help me, Margaret, 19, a fair number of local committees, and therefore, you know, we would be sharing the data with them to inform, you know, decision making around that. So I think that's the right locus for that. We are at 12:35. If we could maybe take a break now and come back by about 1, we have lunch, and then we'll come back for the rest of our agenda.
Things that were identified by the executive committee when we talked about creating the agenda that we'd like to discuss. That's one topic that we've got. And then we also will move to some updates from the subcommittees just to get a status as to where they are, whether or not they've had any recent meetings, and whether or not there's any issues or concerns that we need to be aware of. Okay? All right. So let's start out with the first issue. I know many members have expressed concern regarding some recent media issues.
Sure. I don't know whether it would be productive for, and I don't recall from the email traffic, which of the members specifically raised the concern, but I think it would be most helpful if whichever members had raised the concern could just give the context for what they're concerned about. That would be very helpful.
Private discussion about that. The whole
Mary, I think you need to get a little closer to the mic.
The whole idea of the Justice Center was to look into the types of potential abuse that could occur, particularly in residential settings, and that this could have happened in a large, I think it was in the Bronx, a large, that's larger than your average group home. It's unconscionable what happened there. I'd just like to say, as a backup of that, there have been a lot of complaints, and one of the things I would like to about the Justice Center is that it delays the whole process. For example, of us onboarding staff, people in self-direction, who have care workers who we're trying to process. It takes anywhere from 2 to 3 months to get a person on board. And in an emergency situation like I'm in right now with 3 people down, you can't get staff on board. People who leave without notice, because all the resumes have to go through the Justice Center. Well, how much background checks have they actually done on the people going into these group homes if all resumes of people hired through OPWDD, they want to hire staff, the resumes have to be sent first to the Justice Center for approval. Well, it is at least in self-direction. That's what we're told causes the hold-up in the delay in us onboarding staff. And
Not all candidates, just the person you want to hire has to go get vetted.
yes,
Right.
yes. But my question is, and always has been, because I use both CDPAP and ComHab, the state requires fingerprinting of individuals who work with the families, and particularly in our homes, but they don't require drug testing. CDPAP requires drug testing, but not fingerprinting. So the city requires one level of control, but the state does not require drug tests on individuals who work with our families. And I wonder why that is, and I wonder, with all of these things that come out and complaints about the Justice Department, about complaints that families make, the whole concept of them being put in place was to avoid everything that happened in the Bronx. And if we have to rely on...
Mary, can you speak into your mic?
If we have to rely on the New York Times to give us information on what is happening in our own... Oh, sorry. Oh, yeah. What is happening in our own system, that means the Justice Center is not doing their job. I mean, plain and simple. So I think as you're talking about efficiencies and ways of saving money, one of the things you might consider is, for example, I can't use half of the ComHab hours that I have because of staff overturn. When they leave without notice or they leave with notice, and I can't hire a person quick enough, I lose all those hours, and I'm struggling and overwhelming my CDPAP hours staff with work that should be done by someone else, or me. Usually it's me. Usually I'm the backup provider. So there are ways that if you're looking for efficiencies, that you can look at those issues. What are, in actuality, what is the Justice Center doing? I think, and from what I read from the New York Times, we would be far more, would be better served by reporting it to the police. I believe anyone who harms an individual with a vulnerable person with a developmental disability should be held accountable by the police, because they're certainly not held accountable by the Justice Department. And one of the things that was evident in the past was what I always called recycling the garbage, meaning people who had done egregious things to our family members were allowed to continue in their jobs because of whether it was the union or whoever it was who interfered in that individual being immediately taken away from the situation. Didn't happen. And the most vulnerable population is not served.
I'll just say a couple of things. I think Roger has a better understanding of some of the details, but we found the behavior that was described in the newspaper to be appalling. I mean, it was appalling behavior. There's no excuse for it. It's completely unacceptable. It's very distressing to us that individuals who engage in the types of behaviors that were described in the paper can continue to be employed, because we don't feel that we can adequately protect individuals when that's allowed to continue. The second point that I would make is that the Justice Center was created in order to create an arm's length relationship between OPWDD and the investigatory body, to separate that function from OPWDD in order to give people an assurance that OPWDD wasn't covering up bad behavior or enabling the continued employment of individuals who really shouldn't be serving, our individuals and loved ones. So the purpose of the Justice Center was to create that arm's length relationship, that independence from OPWDD. And as a result, we don't have control over the Justice Center. That's the very premise was separate it from us so that everyone in the public was comfortable that there was an independent entity responsible for ensuring that the workforce was providing safe and appropriate care. So it's not something we can control. There are boundaries between OPWDD and the Justice Center, and there are processes that overlap, and I don't know those as well as Rogers, and he can talk about them. But I think the 2 points are, first, we are really disturbed about the behavior, not the article. I mean, it's fair, people want to make that information public. There's nothing wrong with that. But the behavior is completely unacceptable. And second, folks need to understand we don't manage, control, influence, or direct the Justice Center. Its purpose for its existence was to separate that function from us.
Commissioner captured it very well. I mean, I think just perhaps two other elements to this. In the case that the Times was discussing, in fact, there was an independent investigation conducted by the Justice Center that did, in fact, make a number of determinations against employees, and OPWDD did, in fact, want those people not to work for us because we moved to terminate them all. Those terminations, there is a process that is captured in the collective bargaining agreement, and those employees avail themselves of that process. So I think from the perspective of both the Justice Center and crediting the Commissioner's point that we don't control them, but they did their job. They've fully and thoroughly investigated the matter, and we sought to terminate it based upon the results of that independent investigation. We didn't achieve the result of termination, but that's the result we wanted.
But it goes back to my point. What does it all serve if they are an investigatory body that has no power to remove the individual? Wouldn't it be far better to make the report directly to the police and have the individual taken out? Because that would be a better safeguard for people in those residential settings.
Tammy?
There's a couple of things. One is you can always call the police. Calling the Justice Center does not preclude you from calling the police. But I think a point even more important is that there are things the Justice Department finds that the police would not find. For example, let's say an individual was being mistreated verbally. The Justice Center may find that person liable, or it may be a founded situation that that person should not be working with our population. The police would not do anything about that. So I think and I think there may be a lot of people who disagree with me on this, but being a parent, I think there's a need, and I think there's a need for us to not be rehiring in the system. You forget that it's not just OPWDD that hires and uses the Justice Center clearing. All the nonprofits do that as well, and the nonprofits don't have unions, most of them. So there's that ability for a nonprofit to get a recommendation from the Justice Center and for the nonprofit to decide whether or not they're going to terminate without having to worry about a collective bargaining agreement. I think there is value. That's my humble opinion. But I think we need to understand that you can still call the police. Should you want to, as a parent, want to call the police, by all means you are able to do that. But I do believe that it's also good to have this separate entity that will track those people who should not be working with our population. And that's what that's for, or at least that's my understanding of it.
Michelle.
I just want to publicly state that in the past, because I get the separation, the Justice Center, you're not running the Justice Center, right? So it's a different thing. But I do think it's important, particularly with a new commissioner here, for it to be known that we've had conversations about this in the past. And as part of those conversations, and it was a situation that had happened that was in the paper regarding mistreatment and negligent care, really, of an individual at a group home in Syracuse. And it was at that time that we were bringing this up through the advisory council. And one of the things I asked for at that time is that I do think it's appropriate for the advisory council, who is advising the commissioner, that we have more information about what happens at OPWDD in terms of incident report management, the surveys that get done of residential facilities, and I recognize there's a lot of legal reasons that you're not going to be reporting to us the results of your oversight activities necessarily, but for us as an advisory to understand a little bit more about what OPWDD does in terms of that, it would be appropriate for us as an advisory council, and I also think would be to your advantage, because we are out in the community, as other people have mentioned. People ask us questions about things, and when these types of things are in the paper, it would be great for us to be able to say, well, we understand, this is what happens, at OPWDD when they're going in to, do a quality review of a residential. These are the types of things they look for. When they find problems, this is the process, for resolving that and following up on that, and I think that's a parallel to this comment that Mary's bringing up about the New York Times article and the Justice Center specifically. It's a role that we could have here, and I think it would be appropriate for us as the council to have, and I've called for that before, and I just want to call for it again.
So I think that, and I don't recall exactly when we're meeting again, it's quarterly, so I'm going to guess September. I think we can certainly put that. I made a note as well earlier when there was discussion, I think from Donna, around workforce challenges and opportunities. Those, I think, would both be very good, subject to the council's desire to have those as topics at future meetings. I think they both make a lot of sense. And we do have a very robust process at OPWDD, one that looks not only at individual incidents, but trends, one that looks at provider performance in terms of looking at, whether the provider is consistently delivering quality care. There are, I believe, 9,000 site visits that are made annually by OPWDD surveyors. When we have our head of quality improvement, she may have a different figure, but I believe that's the number that she shared with me recently. So we have a very robust network of oversight, and I think that discussing it and sharing information, and if you wanted to share with Nick or the other members of the executive committee kind of the specifics of the presentation that you'd like to see, we'd be more than happy to provide it.
And Roger, I would just add that when the CCOs, when MSC transitioned to Health Home, OPWDD kept its more aggressive incident reporting processes in place that are much more substantial than even DOH. Now the health homes have both to deal with, which is not a bad thing. I mean, it just gives that additional level of reporting, and so that stayed in place.
Yeah, and it would be great for us to understand that.
Yeah. Okay, Susan.
I understand that
Can I ask? Thank you.
I understand the separation of the agencies. I understand that OPWDD would have preferred to have these people no longer work there. To me, that's where the problem lies. What can we do about that? So where does the fault, and I'm going to say fault because it's a problem, is there problem solving that we can do about it, or that OPWDD itself can do about it? Do the people who have made the determination to not fire these folks, and around collective bargaining or whatever, do we need to do training of those decision makers? Do we need to be doing advocacy? Because if we don't do anything, we're sort of saying it's okay. This is the way the system works. And OPWDD is the state agency that takes care of this population. So I guess that's what I'm interested in. What problem solving can we do around it?
So as I mentioned before, when I talked about stakeholders, we are part of the administration, and there are things that as part of the administration we can discuss very openly and candidly amongst ourselves, and there are things that as a part of the administration we can't discuss publicly and advocate in a larger audience. I said before, we were really unhappy with the outcome. We would have preferred that we could terminate the individuals and ensure that the individuals we care for are safe and healthy. And we will continue to take that position internally with the administration and advocate to the logical conclusion of that. But it's not, I don't think, something that I would be comfortable discussing in a public role and encouraging people to take a position on in public advocacy. Although I can say I think the author of the article was very clear and helpful in pointing advocates in a direction to try to address the fundamental issue. So, I'm not going to try to dodge it, but to say it's really important to us. We are working within the administration to address it. It's a very difficult problem, obviously couldn't be resolved prior and still represents a challenge to us now. But the author of the article was very helpful in giving advocates an understanding of the issue and suggesting an avenue for further work. That's kind of the best I think I can offer you on that.
Just want to add to that in reading the article, it does say that there was a comment by the public relations person in OPW where the staff were retrained. Okay, so I think for most people who read the article, they don't understand the difference between the Justice Center and OPW. So it really ends up to be, it's a horrific situation, as you said. It's just abhorrent. But it ends up to be a very bad PR for OPW, very poor. And so for that alone, I'm glad we're having this discussion. And also, my daughter is in a IRA, and I had friends who read that article and said to me, "Can that happen to her? Are you going to take her out?" I mean, there was that kind of reaction, So, and it's what, parents think about at 2 o'clock in the morning, it's our lives. So I just would want to kind of emphasize what others are saying. It may be different, but I feel that we all, as members here, need to be informed. Like it shouldn't be reading about it in the New York Times if we don't know about it, and it's going to be out there for everything. I mean, that just goes back to our role here, to really get a better understanding of, has it changed, where are we going with it? But I just wanted to add that comment, because it did cause a lot of discussion when we read it.
Try to help create an expectation that we could fulfill, which is, I think, that, you know, at the level of policy and kind of systems advocacy, we're happy to work with you and talk about this issue, and actually, I think if we can discuss it at the aggregate data level, that's helpful. But I would not be willing to discuss in this type of venue a specific incident or allegation. In many instances, they are the subject of ongoing litigation. But in general, I'm not sure that specific instances help us understand how the system at a macro level is working or not. So I just want to help set the expectation. I'm willing to work with the public in general, but not at the level of specific incidents, individuals, cases, however.
Well, I would never expect that.
Okay,
But
so-
I would expect to know if there's going to be an article. I would hope that we would know if there's going to be an article coming out, that we are told about it, so that, you know, there isn't the shock. Part of what you asked earlier, Roger, was who else may have had concern about this. One of those members is not here today, and that individual also wanted to call in today specifically for that, but we don't have access to that. But, you know, later on I could give you that person's name if you wanted.
Let me just take that a little bit further. So we get many, many, many requests from the press about innumerable topics. And the response to those requests is generally fairly open and transparent. We don't know whether those requests will result in a publication or advocacy or whatever purpose will be served by responding to that request.
Okay.
In addition, we get requests through the Open Public Records Act, and we don't know, again, what the purpose of those requests will be, but we do know that a request has been made. So in the course of those processes being played out over time, reporters may engage OPWDD, the Justice Center, or the state in wanting to discuss materials that they've received. It certainly would indicate that a public article or some kind of material would be presented. But again, we don't know what is going to be said because we're not the authors of those materials. So I heard what you said, and I want to respectfully say that if we know an article is going to come out, I don't believe we're going to be in a position to share that with this group. We're not going to make an announcement to the DD community at large and say, heads up, there's an article coming out in the New York Times or some other venue. We don't know what the content will be. We don't know what the purpose will be. And I think it's just not really going to be a constructive effort to say, we think this is coming and therefore we're going to tell you.
Can I just address one point of substance about the comment about retraining? And this is on a global level. When there is a credible allegation against an individual who is a state worker supporting individuals, we put that person out of work. We suspend them, put them on administrative leave, dependency of the whatever administrative process. And once, assuming the case is substantiated, as the cases were here, then we would continue to keep them out of work. Here we were seeking termination. At the point where an arbitrator were to decide that the penalty of termination is not sustainable, we're under an obligation to return that person to work. At that point, one of the things we do, and did in every instance here, which is what the press statement was intended to get at, is look at what led to the incident for which they were substantiated? And is there some kind of training? Is there some kind of reorientation? Is there some kind of enhanced supervision? And now I think all the circumstances we looked at in enhanced supervision that would mitigate the risk. The person's coming back to work in one of our facilities, and we want to make sure that to the largest degree possible, there won't be a reoccurrence. So that retraining is once we've been defeated in our primary purpose of having the individual be terminated, we want to say what other things can we do in the interest of the safety and health and welfare of the residents of whatever group home we're talking about. What can we do to retrain that worker so that they're less likely to be neglectful or abusive? So that's I think it's a positive that we were retraining at that point.
It's the way as you say, the author of the article, it was the last thing that was in there, and it had a different impact upon Reed. So I just wanted you to be aware of that.
Very appreciated. Very appreciated.
Yeah, and I just don't want to create an expectation for something that we can't meet going forward.
Okay.
So
all right, thank
just want
you.
to be honest about that.
And I think the net of the email thread, and there was multiple email threads on this subject, was what steps are being taken to prevent this from happening in the
again.
future.
And
That was, I think-
protection for whistleblowers. A lot of staff are afraid to whistleblow on their colleagues because of fear of retaliation. And how can we work to protection of
Whistleblowers are protected by law, so they should not be afraid to raise complaints or raise concerns. They have significant legal protection.
All right, very good. Second item that I know was raised by the advisory council was information sharing. And I think the point there was how can we facilitate better information sharing amongst the council members on topics. Margaret, did you have... Is there any comments on that? I mean, that was something that I know was brought up. Mary?
I often inform the council members of things that I find out through the system, through my parents, and the fact that we're having such a public, open meeting today was one of the parents on my listserv who, Roger, she brought up the question at the JAC when two of our parents were almost thrown out of a meeting. Educated lawyers who happen to be parents. They pursued this, and that is the reason we have this meeting webcast again today. Our parents, and so I receive a lot of information that I share with fellow council members because we have felt and we have requested information, one of it being that we get the agenda at least 5 days in advance and any supporting materials that are going to be discussed at a meeting. The past couple of years, we just have been preached to, and we come to a meeting and we're presented with documents that we have no time to read, and yet we're supposed to discuss them. I have personally requested this for years, have the agenda and materials that will be discussed in the meeting provided to the council at least. I've requested a couple of weeks, but I believe 5 days is a minimum, and we always seem to get the agenda the day before, no supporting materials, and just to go on, there is a lot of feeling by parents on the ground and by families that they have been abandoned, because a lot of the people who they reported to in the past, we lost Kate Bishop, for example. Nobody's replaced her, not that I know. Parents have care coordinators that they don't know the name of their care coordinator, contact with. There's a lot of feeling on the ground that they don't know who's in control and they don't have potentially a good interaction with their care coordinators or whatever it is. But there's this feeling of a total lack of information going out. And a lot of information is shared on our listserv. A lot of information that parents accidentally through life or through whatever find out information and they put it on the listserv. And if I think it's appropriate, I share it with fellow council members. So as far as sharing information, I do that. And I think it's a service that is, we need to be informed. If we're going to be good advisors to OPWDD, to the people that are our family members and who we serve, sharing of information should be welcomed. And the more we know, the more we can address the problems and work on them to resolve them. It might not always be 100% to our satisfaction, but at least the question is on the table and we can discuss it. There's sort of been a feeling, ground feeling, that parents feel completely we don't get to everybody. We just get to parents who sign up with us, who know about us, hear about us, and sign up around the state.
So, Mayor, you're bringing up two different issues. One is communication amongst the council members on key topics, and then the second is how is information shared with parents in the system?
No,
Well,
I'm not. What I'm bringing up is, yes, that parents on a ground level, they're not getting the information because care managers in majority, unless they're past, which many of them are not, a lot of them are not, they're giving, not only are they not giving information, they're giving disinformation to families. So I find parents asking, oh, my care manager said this, and 7 parents will answer, no, that's not right, that's incorrect. And so
Okay,
I'm seeing this
so-
back and forth.
But there's 2 points there,
Yes.
and I think we
And
agreed
sharing
as a
with the council.
So we agreed as a council that information would start, that much of the information would start with the subcommittees, and that we've got the subcommittees in process, and that those subcommittees would report out, which is what we're going to move to in a minute. But then, in addition to that, that we would collectively agree and prioritize what topics that we did request information from in this forum when we do the quarterly meetings. So, for instance, some of the information that the Commissioner shared with us today, that Roger shared with us today, we talked to Josie about that in the executive committee. Now, we could always look to improve that process, but I think we have that process in place so that if things are coming up, we've got some concerns that I know one of the subcommittees is going to report out on in their session. So I just want to make sure that we're separating the two issues because I do think they're two different issues.
But for example, Neil, who has been with us for years, has disappeared off the scene. And I just found, because I asked the question this morning, that he's moved to another position. But none of us council members who've worked with him for years, he's been fantastic with us and very communicative. And we could ask, he just disappeared off with no explanation. Now, I know the explanation now, but I didn't know before.
I think I'm happy to talk to folks not in this public forum. I don't think it's people change jobs within organizations. People change jobs, and some people retire, including someone you mentioned a little bit earlier. But I don't really want to get into the specifics of people's own.
They usually say goodbye, unless you're a former commissioner.
I really think it's not the best forum to discuss particular individuals' career paths, and I'm happy to share with you after this. In terms of communication more generally, I think we do understand there are challenges in communicating to a large and diffuse groups of individuals, of families. We have 140,000 people whose lives we touch in some fashion, and then you multiply that by their family members, and you have not great ways to directly reach those individuals. So it's something we struggle to accomplish, and we try a lot of different tactics to accomplish it. Webcasting today is a way that people throughout the state hopefully could hear and understand some of what the current thinking is. The nature of this body is it's a quarterly body, so there are the pace of events in life sometimes doesn't moves more quickly. So there may be other venues, there may be other opportunities to communicate that don't wait for a quarterly meeting. And I want to just capture something the commissioner said, which is I think this group does best when it's at the strategic, at the policy-making level, because there is a rhythm to that. And so, if there are key issues and areas that, as representatives of a larger community, need to be addressed, it's a wonderful forum for that. And I think, all due credit to the parents who advocated for open meeting. I think it's productive because it means that we're going to be in an opportunity to multiply our message beyond the specifics. I do want to make sure we have enough time. I know there were a couple of the subcommittees, and then we do have a public comment period, and I know there's at least a couple of people who have come to make public comment. I want to respect that we maintain enough time on the agenda to accomplish that. So I don't know, Nick, if you have those, yeah.
Just one quick point, and not to be disrespectful, but I'll be honest, I did not know as an advisory council member that we would be doing subcommittee reports today, because the agenda came out around 1 o'clock yesterday. It said it's going to look different because we're going to try a new format. We want more discussion. There's nothing on the agenda that talks about subcommittees. So I found myself very confused and thinking I was going to be coming here to hear, like, how are we functioning going forward? Because we had put a lot of time and energy into the subcommittees as a way of getting, a deeper dive into issues because we only meet quarterly as a full body. So just that is a confusing piece of information.
Yeah.
No disrespect. I just have to tell you how it plays off to people receiving
no
it.
disrespect at all. I frankly defer to the executive committee in the agenda as a product of that discussion. So in putting out the agenda, we are passing through the work of the executive committee. We're not engaging in our own creative writing in any fashion.
And I would say that was an oversight because we've always had subcommittee reports, so.
I thought they were disappearing from the text of the email and then looking at the agenda, so, okay.
There was somewhere a communication breakdown between executive committee, agenda, actual drafting, and agenda publication, and I think that's something that's an easy fix moving forward.
And our intent is not to put them on the spot. It's just to find out if there's anything new regarding their subcommittees, any concerns that have been identified in those subcommittees. Susan.
Be really quick. As an executive committee member, it would be really helpful if we came up with the agenda a little bit sooner than we have been. And nobody knows better how busy things can get. But if we had 2 weeks in advance we were going to meet, because I wasn't able to come to the phone call because of that.
Right.
Is it possible to have copies of the PowerPoints at the meeting? Is there some reason why that's not allowed? It would be very helpful. I'm thinking of when various people have presented with huge PowerPoints. If we had them at the meeting, we could take notes on them and so forth.
Sure. No reason other than I don't think anybody had asked us, and I make a habit of not wasting trees. But if
We have asked.
Not that came to my ears, so I apologize for that. But we can certainly, moving forward, make available printed copies.
Can I say something? I haven't shared my PowerPoint with anyone because
Is that the roadmap?
No.
Is the roadmap something else that we're not aware of?
What I presented this morning were my
Your
thoughts and feelings and just general topics for discussion. And so I haven't shared them because I'm worried that they are misinterpreted as a roadmap or policy. What I'm trying to do is just get people to start talking and thinking.
I get that. I wasn't
okay.
thinking
No.
of your PowerPoint actually, but we've
There are a
had
lot that
people
have-
coming and talking about very detailed
Yeah.
topics.
If we're doing a presentation next time, which sounds like a request, and I'm respecting the executive committee's filtering of that, so maybe, if there's a presentation on what do we do, what's our quality strategy, and how do we engage in DQI, and there's facts and figures and numbers, I could see that as being the kind of presentation that would make 100% sense to have in written format and share.
We knew there was not going to be a formal presentation, as the commissioner said. Normally, the commissioner's comments are not.
Right,
I mean,
right.
he went above and beyond today with a presentation, but we knew that there was not going to be any. We wanted to keep today more of a dialogue.
I
so-
wasn't talking about
No, it's
today.
okay. No, I'm not worried. I don't take any offense at it. It's just that.
But yeah, Neil knew that. I mean, we always tried to get them out both electronically, not all the time. Again, and sometimes it depended on the presenter and whether or not they were prepared. But we'll work with Josie to make sure that any future presentations are given. And we'll also, now that we have Josie in place, we'll be on more of a rhythm on the executive committee to.
Can I ask what the roadmap is? I believe it's been presented to other groups.
I'm
The JAC, and I certainly know to some parent groups, and it's come across as a question on my listserv, and I don't know why we don't know what the roadmap is or haven't had a presentation on it.
I'm happy. I mean, and once again, if that's a request, I would say, tentatively yes, pending filtration through the executive committee. The roadmap is a document being developed currently in draft format. We have a data management group, and I think one of the pieces in the commissioner's presentation that came through loud and clear was a need to increase our IT capabilities across the agency, increase our ability to meaningfully engage in data analysis. And the roadmap is simply an internal working document that we've been working on to figure out how we do that. If we have lots of gaps, which are the first ones to be addressed and which ones are the next ones to be addressed.
But it has been shared with parent groups who claim to represent the whole state, but they do not. It's just 9 individuals. And it has been shared with other committees, and I wonder if there's any reason that documentation hasn't been shared with us as an advisory body.
I think we can certainly talk about that at the next meeting if we'd like to.
And I would just remind everybody that if anything that's shared at the Joint Advisory Council, that is held here and is actually webcasted, so people can.
These documents from the roadmap were shared with the parent group, and so I wondered if it's shared with the parent group, are they the official parent stakeholders, or should we, the council, be apprised of what this roadmap is?
Well, I'm not aware of a practice of sharing draft documents, so let me go back and look into it and find out exactly what you're describing.
But they have been given access to these documents, that I do know. Wondered why we
can't
weren't.
speak to any specific details about that. I'm not aware of it, although I would be uncomfortable with
Maybe
the
you
sharing.
should join my listserv.
Well,
It might be informative.
So let's move on to subcommittees. And again, it's just whether or not the subcommittee has anything new. Margaret, I know your subcommittee did have a meeting.
Yes, last week.
Sorry.
Yes, we met last week, and we began with a presentation from Dr. Kastner. It was a very mini version of what we heard today about going forward from CCO.
You need to move it
How's this?
closer. That's better.
Okay.
Thank you.
So then we had a presentation and discussion with Jackie Best, who is the Regional Office Statewide Operations Director. about the Family Support Program review and discussion, heard about today. The only thing I would add is, the purpose, just to underline, the purpose of the survey is to assess accountability and effectiveness of programs, especially in light of the change in the service system from especially service coordination and care coordination. So the problems pointed out by Dr. Kastner, again, were equity, which we heard about today, and also current relevance and quality of programs. So the survey, as I understand it, having not yet seen the document, a lot of fiscal issues, the utilization of the service, how much money was spent and on what, the cost structure of the services, that sort of thing. And we, the parents, were wondering what there was of the programmatic side. And that's why we asked to be part of it and to be part of the planning going forward. And we will see it, not the final version, right?
Yeah, I assumed that there would be ongoing conversation, and it sounds like it hasn't happened between last week and this week.
We haven't gotten the document.
Okay, so we can
We're
follow up
waiting.
offline to make sure that happens.
Yes, and then we will be able to give input without waiting until the next meeting, quite a ways off. So we also had a brief presentation on the budget that was enacted, just to bring anybody. We had some newer members at the committee, and in case they asked if they needed an update on it, and so we had like a 2-second update that there's money in the budget and that there's 2% DSP increases, but they're really for next year, January 1st and April 1st of next year, 2%. The first is, I think you said this earlier, support professionals, and the second is a little broader. It includes clinical personnel as well.
I totally missed that because I couldn't hear my, but
I'm
what was
so
the 2%?
sorry.
I'm so sorry.
Move it. Direct support professionals are slated to get a 2% increase January 1st, and there will be a second 2% increase
Don't look at me, though. Just look at your mic.
Just look at the mic. Don't look at it.
I just need to hear you. I know what you look like.
Okay, and the second one is for DSPs and some clinical staff as well. Okay. That was the budget. In our conversations on the phone, we were talking about the something else, and it came up that certain members felt that there was a tremendous dearth of opportunities for services for people who are behaviorally difficult to serve or medically difficult to serve. And we had a little discussion led by one of our members, Jody Mulmeister, about the need for such services. They include facility-based respites, socialization, the difficulty finding workers who are willing to work with this population, lack of site-based day programs, weekend respites, and a few other things. And we were very concerned to hear how underserved these people are. We were not surprised. We know this. But to have it all put together this way was very powerful, and we recommend that this be a top priority for OPW going forward. Then we had a presentation by Mary Ellen Moser on the staff action plan, which is what replaces the former ResHab plan. Know what that is? So it's in the life plan, individuals establish goals for themselves, and the staff action plan details how those goals will be addressed. The goals are assigned to the provider in order to help the individual reach the goal that he or she has set. And that's kind of the big difference, that the provider is now assigned these goals for them. The provider's goals are in order to help the individuals reach their own personal goals. So that was very interesting. And then we had an outstanding presentation by Allison McCarthy on CFCO, of OPWDD, on CFCO implementation. I wouldn't attempt to summarize it. It's very complicated, but basically it's and then correct me if I get this wrong, certain people who are in Medicaid, there's 4,000 people who are in Medicaid, mainstream managed care plans already.
That
Am I
have
mixing that up?
CONHABs.
No, I'm mixing that up.
Margaret?
Yeah.
In terms of PowerPoints that we should share, why don't we send that one around?
Yeah,
Because that may save you trying to
Okay.
explain that,
Okay.
which I think the PowerPoint does an excellent job.
The bottom line is certain people are eligible for this CFCO service, which means that they can get ComHab and what are the other ones? Essentially, mainly is ComHab, without going into the waiver there. It's
The
supposed to
PowerPoint
be
will address that.
seamless. It's supposed to be, the bottom line is it's supposed to be seamless for the individuals. They'll get the same service, but the provider will have to deal with billing. It can be complicated if you have individuals in different managed care plans. So that can be viewed as an opportunity to learn, and that was for the providers to learn. So, and that's what we talked about.
I think it's important to note that that presentation and a really great 8-minute YouTube video that goes along with it has been publicly posted on OPWDD's website. So it's available to anyone who might be listening to the webcast. And I think OPWDD did a really great job with that based on feedback in part from us saying that we really felt that something needed to be publicly available that was understandable to families about it. And I think it was done very quickly and very well done. So thank you.
Great, and I guess I didn't know that, so that's wonderful.
Yeah.
Thanks, Michelle.
Thank you.
I know many providers actually appreciated that post.
Yes.
Because they too
Yeah.
are, in some way struggling with this. And Margaret, just getting back on the individuals who have the medical, the higher needs individuals,
Yes.
that may be a topic that we as a group want to take up. I know that there was a conference that was done on that population a couple of years ago.
a
Haven't
few
really
years ago.
heard where that has progressed and what we're doing to meet those individuals who are on the higher end of the need spectrum.
That's a very good idea. Thank you.
So why don't
Yeah.
we, Josie, why don't we put that as a follow-up action?
Good.
Okay, great. Thank you. Susan, did you have anything from?
I can be very short. We are thrilled to say that after 9 months, we seem to finally have a meeting scheduled.
Very good.
So that's where we are.
Okay, good.
So next meeting, hopefully, we'll have a report.
Okay, very good. Dolores?
Yes.
I am so
Sorry.
sorry. That was a little confusing. Yes, that was the employment and post-secondary meeting.
And that group looks at opportunities for individuals who have graduated from high school and are moving on. What kind of opportunities are there for them? Is the Family Support Services Council. Dolores, System Subcommittee?
Systems Subcommittee.
System Subcommittee, and again, for the public, System Subcommittee focuses on major systems changes. Things like waiver, things like managed care, things like CAS assessments and CCOs and all of those complicated topics.
Yes. So I'm very happy to say that we have 4 new members because we were struggling for quite a while. So I'm very excited about that. We have 4 or 5 different priorities, but we have been spending the last couple of months really formalizing recommendations around the front door process. We have some really great ideas to make some positive changes in that, and so we hope to have that in writing to everybody next month.
Right.
Michelle, was there
I would just, for clarification, say that we're focusing on the front door because we think that it's a really key point of information sharing for families about the, what they're entering into with a CCO and what to expect from care management. So that's why we're spending our time there.
Yes, absolutely.
You guys will
Waiting
come
on-
back with recommendations.
Recommendations, and we're waiting on the CIP-PL qualifications document, which will be.
Thanks, Dolores. We have a residential subcommittee. John? John Maltby is representing the residential subcommittee.
Did you get any of that? Okay. In brief, our committee met and prioritized the various issues that we've raised and considerations and recommendations that we have made over the last couple of years, and we will be providing the Commissioner and Roger with a summation of those issues and their priorities, plus some background information to help them consider them, and we will be happy to talk at the next full council meeting. There was one issue that came up that was rather timely, and I'm not an expert in it, so I'm going to read from my notes, if you'll pardon that. I promise not to take too long. There are planned changes in the Consumer Directed Assistance Program, known to us all as CDPAP. For those of you not familiar with CDPAP, it's a Department of Health 1915K waiver service that is used also by people with intellectual and developmental disabilities. The program helps people with medical need for help with activities of daily living, skilled nursing, and it also allows for the worker to administer medication. Under OPWDD's waiver, unrelated persons can only administer medication in a certified setting. So the change that is proposed is that in the 2019-2020 New York State budget seeks to redefine who can be a fiscal intermediary, an FI, for providing CDPAP services. The budget increases the scope of activity that an FI must perform, amends qualification standards to be an FI, and moves from current fee-for-service to a per-member, per-month basis, so a sort of managed care capitation rate for administrative compensation. One of the explicit goals has been to reduce the number of FIs. For us, this is an issue because the change is in fact likely to reduce the number of FIs as originally intended. The increase in scope of work and the projected reduction in administrative reimbursement by more than 50% makes the service untenable for a large number of FIs, including those supporting people with intellectual and developmental disabilities. Stakeholders are concerned at the potential lack of effective FIs that will result and the gaps in coverage that will result from transitioning between FIs or from FIs that have gone out of business. The Consumer Directed Assistance Program of Association of New York State, which is an acronym that I can barely pronounce as an acronym, is an organization seeded by the Developmental Disabilities Planning Council some 20 years ago, and which represents people with disabilities and fiscal intermediaries. CDPANIS projects that every FI in the state will go bankrupt under the current DOH proposed formula. In some situations, rates will be drastically lower than the 50% cited. As an example, an agency serving a person for 37 hours a week will be paid an administrative fee of 40 cents per hour. In discussion, one of the agencies represented on the committee said that their CDPAP serves over 100 members. They project that their administrative income will go from a small surplus of about $50,000 to a net deficit of about $600,000, and they will get out of the business. So the effect to OPWDD, because as Roger pointed out, this is not OPWDD's waiver, but it's a DOH waiver. But the effect on OPWDD services will be as follows. People with intellectual and developmental disabilities may not be able to obtain the personal care services they need to live in the community, including those people needing support for feeding tubes, respiratory help, and medication administration. That's any medication. People may have to switch from CDPAP, for which the state pays $19.46 per hour, to ComHab, for which it pays approximately $41 per hour. CDPAP can provide overnight care, ComHab cannot. CDPAP can perform health tasks, ComHab may not. People may have to move from self-directed community housing into certified settings, assuming such is even available, exacerbating our current housing crisis. The potential for unauthorized administration of medication is heightened. The requirement to hire non-related DSPs will exacerbate our labor problem. Taken together, all of these factors negatively impact self-direction, promote institutional bias, and are antithetical to the spirit of Olmsted. The financial impact to the state from a single person moving from a community-based home into a certified setting will doubtless vary from person to person. For a person with high level of needs, that difference between the highest available personal resource account and a supervised IRA could amount to between $50,000 and $75,000 annually, perhaps $2 million over the remaining lifespan. We do not know how many people are supported by OPWDD who use CDPAP to help them, but we do know that were it to be only 1,000 people with that kind of cost increase, it would be in the billions over the person's lifetime, over the group lifetime. The current status is that DOH has postponed stakeholder work group meetings in order to review information. The committee proposed that the council consider the following steps by OPWDD. First, establish how many people with intellectual and developmental disabilities use CDPAP services. How many people with intellectual and developmental disabilities are supported by OPWDD provider agencies acting as FIs under the CDPAP waiver? The impact on people with intellectual and developmental disabilities if FIs can no longer support their services? And an estimate as to the risk of increased costs to OPWDD from essential reinstitutionalization of people currently living in the community. We did not look at the impact to the Office of Temporary Disability Assistance, which would also be substantial. Thank you.
Thanks, John.
Make a comment on that?
Well, I think as John correctly anticipated, we have to defer in large measure to our colleagues in the Department of Health, and since they are the administrator of the program. But I do understand what you're asking, and I think it's something worth looking into to at least understand the potential impacts.
I can say from my listserv that a lot of parents who have developmental, a child with a developmental disability, including myself too, who use CDPAP and self-direction services, for example. And I would not be here today if I did not have CDPAP services. And even then, I just conducted in my lunch break tube feeding training over the phone, because 3 of my people left with no notice, and the only way I could get somebody on board is through CDPAP, because they, unlike going through the fiscal intermediaries with self-direction, they take 4 or 5 days to process a person, whereas it can take 2 or 3 months with ComHab services to get somebody on board. So without CDPAP, many of our parents, by the way, organized the huge rally that was held in New York City to save CDPAP services. And there's a meeting going on today. Several of the people were in the lobby of the importance of CDPAP services. And the state's understanding is that we went from having very few fiscal intermediaries to having 600 or 700 of them all at once. And a lot of the concern was that people who were using old traditional services with the traditional agencies serving the elderly, when the law came into effect that a family member could work as a CDPAP worker, a lot of children of elderly parents took on that position. And so you have to understand that people receiving home care in New York State, it's about 4% are people, individuals with physical disabilities or intellectual disabilities living in the community, and 96% are the elderly. So the elderly usually have been serviced by traditional home attendant programs. And home attendant programs are unionized, whereas CDPAP workers are working for families, so they're not unionized. So when there was this huge influx of fiscal intermediaries come into the system, a lot of them were not trained or didn't have the backing to provide the services that they were supposed to have. And this is when the state got all fluffy and the Department of Health threw the baby out with the bathwater, basically by imposing draconian measures on our population. And our families came out, and it was our parents who organized that rally, and the other agencies moved in.
So, Margaret, I'd like to ask John. John, you guys are going to your team will continue to provide us with an update based on what your providers are telling you with the residential subcommittee.
Very important.
Correct. So the main focus that we have had, which came from both a member of the committee who is a user of CDPAP and from an agency that is an FI for CDPAP, was the financial and social impact on OPWDD services, which could be substantial, and how can we forestall that and be represented in the discussion.
Certainly take a look at that. Thank you.
Yeah, I did want to thank you for that. It was a very thoughtful and I think comprehensive way of looking at the boundary between the two programs, and in particular talking about what CDPAP provides versus what ComHab cannot provide. I think part of the goal on the part of the Department of Health is to make that boundary a little bit more clear, because I think that at the level of Medicaid, there's a concern about one service being substituted for the other, or that CDPAP, ComHab, home health aides, if you look at the M11Qs that primary care doctors sign, they're all perceived as forms of personal support, and technically they're not. So the fact that you kind of were able to help us separate the functions of the two is really useful, I think, for a dialogue about where OPWDD can intervene and provide assistance versus what health is responsible for. So I appreciate that.
We'll report back after our next meeting.
Thanks.
And I think one of the things to commend the residential subcommittee is looking at these different tools, not in a duplicative way, but in a complementary way to support people outside of certified settings. And been working closely with OPWDD over the years to how do you use those two together, and this could potentially upset that balance. And just one point that I'm not sure you made, John, is that some of the staff actually work for the agencies in both programs.
Absolutely,
So if one
so that we
program
can
were
avoid
to
that.
end, it could disrupt the staff continuity associated with a lot of people.
Absolutely, and this includes the very important component of medication administration and the Nurse Practice Act and everything associated with it.
Right, which is a major issue.
Thank you.
Thanks, John. Great. Now, I know Gary had to leave. Had to leave as well, so I don't know if we have anybody representing the health subcommittee. We're going to be meeting with the commissioner. Health subcommittee. Okay, very good. And they've been presented to the council or the council prior to this.
So, Josie, do we have anybody who signed up for public comment? I think we at least had a couple. Thank you. One. The last name is Harvey. I am having a hard time reading the first name. Martine, thank you.
My first meeting, so I want to thank everyone for making it public. I had no idea that there were meetings that weren't public. So I am a parent, an advocate for my son, and a surrogate for an individual with a disability that uses both OPWDD services and the CDPAP, which I learned a lot about, and it's very difficult to manage both of those things. But I want to thank the Commissioner for your opening statements and your information. It's all very important to all of us to understand how things work. Just as important it is, I think, for you personally to understand. I know that you did mention that you personally have some family history with people who need services or someone who needs services. And it's sometimes you just feel like you don't know who to talk to. You don't know where to go for help. And you go to the people that you have the most contact with, which your care manager, your MSC, former MSCs, and we have our agency people that we go to, and I'm too often not able to get answers from people who are supposed to know what's going on more so than I am. I've now been in the system with my son for almost 30 years, and so I feel like I have a lot of experience in many different areas. So one of my questions is, I see that there are certain subcommittees. Is there a subcommittee for self-direction?
Yes, there is, and we've lost our liaison, so we need to reactivate that.
Well, she just arrived. Martine Harvey.
Okay.
I started self-direction about 1.5 years ago and was very upset to find out that it had been around for a very, very long time. And my son is a perfect candidate for something like this and has failed at so many programs that he's been in, because when you have a child on the spectrum, and there's lots of programs out there to help people with disabilities, you get pulled out of mainstream because you can't fit in that mainstream box. And then there's a zillion programs, and every program that he and I went into has a box. And he didn't fit in any boxes. And just recently, about 2 months ago, I was told by someone in self-direction, well, perhaps self-direction isn't for him either. So that's when I got really concerned and really worried, because if you can't do a program without walls, which is what I think self-direction is, it's person-centered. We kind of meet with the person, find out what it is they like, and we wrap a program around them. If that's not for my son, then what happens now? So it was very disheartening to hear that from people within the program. What was also difficult for the program, with the program, is I was told that you go to the first meeting, you have to sit and see the video presentation at the self-direction office, and not allowed to start without that. You have to have your fiscal intermediary in place, you need a support broker in place, and they said it's going to be 3 to 4 months. Well, being a very organized person, I had a lot of the groundwork stuff already learned, I thought, and I'm like, this cannot 3 to 4 months. We'll get this done in like 3 to 4 weeks. Well, 7 months later and 5 MSCs, we finally launched the program. And I won't bore you with the details, but I'll tell you, after 7 months and 5 MSCs, none of which knew what they were doing. They had nobody to talk to that helped them. They had people that there were their supervisors that put up roadblocks for them to help. And my broker did most of the work. I did an unbelievable amount of work, and I don't even want to mention how many hours I've spent to get him involved in self-direction and to keep him in self-direction. We had an ISP meeting this morning, so I'm coming fresh from that. He's not had a life plan done. We were told if you start the life plan now, because we were switching FIs between one and the other, because that's another issue. FIs are allowed to do whatever FIs want to do. They have a list of regulations from the federal government and the state policies, but then they are allowed to make up their own rules along the way. So what one fiscal intermediary agency approves, another one will not. So that puts an awful lot of burden on the individual and their family, because you get used to one set of rules and then you want to go to another fiscal intermediary for different reasons. Mine was staffing. I had a whole nother set of rules. And I understand there's lots of difficulty with the Justice Center, and I get that, But I'm on the other side with the Justice Center, where if it's going to take 3 or 4 months to transfer an individual from one agency to another, and that same person has been through the Justice Center, has their fingerprints in there, has the background check being done, how many times does an individual need to be background checked? Some fiscal intermediaries pay for that, and others do not. So I pay for that, and I reimburse if that needs to happen, because people don't have the money to do that, nor do they want to deal with the aggravation of going to get fingerprinted and all of that. So I feel if they're willing to do that, the least I can do is pay them for it. So that's an issue. I would like there to be a place, as the Commissioner said, how do you disseminate information to 140,000 people, plus each of their family members or guardians who are in charge of them? And it's not easy, but you have to have your army with you. So I find that each service that OPWDD offers should be readily accessible. So finding out services as far as the front door is concerned, I had to literally become part of the community to find that self-direction even existed. Like I said, my son's been in the system. I was told about OPWDD services right before he graduated from school, saying, is your son registered with OPWDD? And I'm like, what is that? Who? And they said, you have not had your son, gone through the process? He's going to graduate, he's going to age out of services, and you won't have anything. So the school district didn't alert me of it. All the services of OT, PT, speech, CSEs, nobody said, you could be maybe getting some help here, some services. There's a whole organization out there, New York State-run organization, to help people with developmental disabilities. So I scrambled, scared for his life and mine that he wouldn't have services, and what was he going to do? And they said, and they're really cracking down on who they're going to give services to, so you better get on it. It could take a long time. And this is quoting, pretty much. So of course I jumped right on it, and he was accepted for services and became eligible for services. And we were only told about programs that were offered by whatever agency we happened to be with. So it's only between talking to other parents and meeting people in the mall, or standing on the grocery line, you just start chuckling and talking to somebody and find out they have someone with a disability, and you find out about programs. And then I wind up being the person who's calling around to all different places to finding out the programs. And when I would go to the different agencies that we were with, they had no problem just saying to me, I never heard of that program, didn't know about it, or that's not our program, I know nothing about it. So I look at CCOs coming on board as hopefully a positive, where there is people that are kind of separate and apart from the agencies, who now their job is to find programs for people with special needs to integrate and give them something to, program to be involved in, and not having the agencies hold on to their people and their programs to, get the money for those programs, because that's all I can think of. You send somebody to somebody else's agency for a program, you're not going to be getting paid for a program any longer. So it was disheartening, because they'd rather see my son not in any program than to tell him about a program at another agency. So he's been out of school now for 10 years. He's going to be, he was just 31. We had, like I said, we had our ISP meeting this morning, and I'd like to take that offline with somebody. It's not for a public discussion, obviously, it's personal. But I'm very saddened to have to even be asking to take this offline to talk to somebody, because as an organized person, as a person that doesn't have a problem talking to just about anybody, my son doesn't really have a program, even though he's in self-direction. And as much as they're trying, and as much as they'd like to help, there are roadblocks everywhere. There are roadblocks between agencies, between OPWDD and New York State Education Department. Then there are roadblocks between OPWDD and Department of Health. The from the IT perspective, that's how you manage hundreds of thousands of people, is to have a very well integrated IT system. And it heartens me to know that you have no way to gather the data that you need as the leader of the of the OPWDD so that you can make good decisions based on your analytics, which you can't really get. So I'd like to talk with you offline about that as well and how I can help. Because at the end of the day, I'm a solutionist. I like to find solutions to problems. What the problem is, we have to identify it. Once we identify it, then we can go after and find solutions for that problem. As far as integrating in the medication with the CD Pass and the ComHab, I have that with the individual that I'm a surrogate for. This man, I was called in to be his surrogate because he wanted to be kept out of an IRA. And if he didn't get a surrogate, he was going to be put back in an IRA. So I jumped right on board because I'll advocate for him just as much as I'd advocate for my own son to keep him from going back into an IRA. I'll take offline if you'd like to understand more about that as well. It's very difficult to kind of integrate. You have ComHab people that are making anywhere from $15 to some $25, $28 an hour, depending upon the agency that they're with, going to CD Pass and they're making $12.50 an hour. Bringing more people on and having them go through the Justice Center for 3 or 4 months is a very lengthy process. Once people find out how much they're being paid versus CD Pass, the only reason why my CD Pass people aren't going through OPWDD is because they cannot pass a background check. They cannot get fingerprinted. And they're leaving people like this with people. And I'm not saying all CD Pass people have this problem, but that's the problem that I ran into, is that my CD Pass people couldn't pass background checks. I'm leaving them alone with my person to take care of alone. That's disheartening in itself. So I'm just going to look down at some of my notes. There are so many issues. I don't know, as your job being so daunting, there are so many issues with people with disabilities that OPWDD needs to manage, that I want you to know that from listening to the people in the room, I speak for myself as well, I'm here to help. I want to find ways to help the issues. You cannot do this on your own. You don't have the time of day to do it, nor the emotional stamina to put it up. I would not. And I'm looking to be on that self-direction committee, and it's very important that they have their own committee. When I had heard about the Family Support Services Committee, I went to the first meeting and was pretty much told that now that I was in self-direction, Family Support Services could not help me at all. That self-direction and Family Support Services do not really cross paths. That any of my issues with self-direction were self-direction issues, and I needed to go to the self-direction office. So there's a huge need out there for a self-direction committee, and I would like to be part of that, to do my small bit that would help my son and my family and many other people in self-direction, because I see a lot of areas where streamlining can take effect. One of the things I do in my business has to do with frameworks. So my question is, is there a framework out there for service delivery systems? And I'm sure there are, and if I did my research, I could find one. But what frameworks help you do is give you kind of lists of best practices and other areas to go for checklists. Did I do this? Do we need to do this? And we need to do that. Try to help you cover bases. So I would like to very much try to apply my knowledge of the system and what I've been through with my son and with the person that I surrogate for, which has opened up a whole nother avenue of services through OPWDD to help with the problems. And I have wanted to come and sit at 44 Holland to run into you and hopefully make an appointment to come and see you. So when I found out that this was available, I said, I'm going to come here and have my opportunity to speak with you personally here, because I'm not someone who just wants to complain, and I'm not looking for you to give me an answer today. I understand process. That's another one of the things that I do in my line of work is process. We don't like it, but we all have to have a process for something. But if we have a problem and we have a process in place and we know how, we can figure out how to get there, because it can't continue the way it is. There are too many people out there that need services, and there are too many hurdles I like to call them hurdles and not problems, because you can jump over a hurdle and you can find a way around. And I know that there are ways around. I know that there are people working at OPWDD, specifically in the self-direction office and in some of the agencies that I've dealt with, that feel the same way, that want to find answers, that want to find ways to help people and not be stuck in a problem, as I was again this morning, because he's not fitting into this box again. So there's an issue there, which hopefully we can solution.
Thank you. Appreciate that, and as we move forward with the self-direction committee, we will certainly keep you in mind.
Thank you.
Thank you very much. I appreciate it.
You're welcome. Sure. And I'm interested in your systems subcommittee as well. Thank you.
Public comment, we're actually at the end of the meeting. I was just going to ask if there was any.
Open discussion kind of
Yeah.
thing. Earlier, Donna alluded to workforce, and I know you said, Nick, that at the next meeting, that might be part of what you bring up. There is something that sometimes with workforce issues, we know that what we're dealing with are global issues, but sometimes they're specific issues. Sometimes they're agency issues, but sometimes they're a system issue. And I think I'd like to bring up an issue that I believe is a system issue. For example, in the city, in New York City, in the Bronx specifically, they are at the $15 an hour rate in the wage increase. Connecticut is at the $15 an hour rate. We in Westchester draw upon those two pools of area for staff. We are not at that rate. And I don't understand why the plan was not to have Westchester be the same as the city, because a lot of the employees that, potential employees that come through to Westchester and up to the northern part also of Westchester, which if you know that area geographically, you're right on the border of Connecticut, but you're also talking about the pool that they draw upon. So if you were to look at the providers, many of their staff are from the southern part of the county. Now those staff have chosen to go to work in the same field in the city, in the Bronx, and we used to draw upon the Bronx to come up. So the work shortage hit like a rock, like it already was challenging, but I'll give you an example. Yes, and we're not in that venue yet of the $15 an hour. So I'll give you an example. An IRA that I'm very familiar with, because our daughter's in that IRA, is supposed to have, used to be 13 staff, then they went to 11 staff. We currently have 2. We have 1 out on medical leave, and there has not been a staff hired into the house in over a year. And it is to such a point that it is a safety issue. It is a huge quality safety issue. And so, of course, we've problem solved. We've sat with them. We've given suggestions. We've looked at all this, and we got a presentation from the agency, we the families, like a broad base of families, got a presentation from the agency as to the COLAs that haven't come, as to the increases in the direct support and when it's supposed to come, as to the wage level, because currently now you can go and work at McDonald's and make that money, but you work in this field and you're now starting at in this particular agency, $12.35 an hour. And so it's terrible. It's really, really bad. So I'm saying, as this is a system thing, is like, do we know when Westchester is going to hit this? Because I don't understand why we weren't in part of the formula that went with the city, because normally we are. And I assume that came from, not from OPW, but the governor's office. But can we advocate strongly for that, please?
And you're correct in the assumption that that is not an OPWDD decision. I believe the schedule for those rolled out increases in the minimum wage is known. It's just not known to me. I think it's there is a schedule for that. I mean, we can look and see if we can find that information and share it. But
yes, I'd appreciate that, because it really is critical. It truly is. I mean, if you went around and you looked at staff that were in the day programs, because I'm very familiar with most of them, you know, serving families whose children live at home, a lot of the potential staff come from large cities in the southern part of the county. And you're not seeing that anymore. And where are they going? They're going to the city.
Good. Any other areas of new business? Thank you. We'll print out the minutes. Josie will work with us on getting that. PowerPoint.
I already sent the PowerPoint. Can I just add one more thing? I am on the residential committee with John, and that committee is amazing. And how he runs that committee and the knowledge that he's able to gather and bring forth. And I know that areas were brought to this committee. How long ago was it, John? The fall of last year. So we as a committee would love to hear the follow-up on that.
Okay.
Like those recommendations. I know it was explained to us that sometimes they're just incorporated within the agency, but we'd like to know the outcomes of those recommendations, okay? But that is, he's just amazing. And your presentation was excellent, John. Thank you.
Thanks, Mary Ellen.
Okay.
I agree with that, and we will make sure you get we will get a follow-up on that. And we will also make sure that the executive committee gets together a little bit earlier now that we've got it ready. Again, thank you for everybody for coming. Thank you for the public for coming and presenting, and we will see you in September.